Have you ever truly considered what makes the body's largest blood vessel, the aorta, so incredibly vital, yet, well, at the same time, surprisingly vulnerable? It's a remarkable feat of biological engineering, really a masterpiece of design, but it's also the site of some of the most critical and um, rapidly evolving medical conditions imaginable. Today, we're not just scratching the surface, we're taking a definitive deep dive into this absolutely crucial part of your anatomy.
Welcome to the deep dive. Our mission here is to unpack complex topics, really extract the most important nuggets of knowledge. We aim to guide you through the intricacies, distill all that complex information, and provide you with a shortcut to truly being well informed, maybe even mastering this subject like the elite professionals in the field. Our source material today is incredibly rich. We're working from excerpts of the renowned SABISTON textbook of surgery, 21st edition, 2022, which is, a definitive guide in the medical world.
And our journey today is ambitious, definitely. We're going to guide you through the intricate, sometimes bewildering world of aortic diseases. We'll start from their very origins in embryology, trace their complex anatomical pathways, get into the various classifications of conditions, and then explore the cutting-edge surgical and medical management options that are genuinely transforming patient outcomes. So whether you're just curious about human biology, maybe preparing for a medical discussion, or just seeking those aha moments that broaden your understanding, this deep dive is meticulously designed for you. We'll cover everything in extensive detail, ensuring you gain a thorough yet accessible understanding of this fascinating and critical organ.
Okay, so to begin our deep dive, let's confront the sheer scope of aortic diseases. Our source makes it really clear this isn't a small corner of medicine. It's an incredibly broad and constantly evolving landscape, encompassing a vast range of conditions that, frankly, can't even be fully contained in a single textbook chapter, let alone, a brief overview. The field is characterized by continuous dynamic evolution, not just in our understanding of how these diseases develop their pathophysiology, but also in the medical and surgical management options available. I mean, what was cutting edge 5 years ago might be standard practice now, or maybe even a bit outdated today.
Right, and that dynamic evolution extends to how surgeons approach this specialty too, doesn't it? Our source highlights an interesting distinction among practitioners.
It does. You find disease-oriented surgeons who focus on a specific condition, like aortic aneurysms, maybe regardless of location. Or you have procedure-oriented surgeons who master particular surgical techniques, say endovascular repair, across different aortic conditions. This specialization just underscores the profound depth of knowledge and skill required. It's also why our deep dive, much like the textbook itself, emphasizes common disease processes and an overview of technical considerations, rather than getting bogged down in rigid procedural descriptions or specific technologies. Precisely because those elements are subject to such rapid change. This fluidity demands continuous learning from everyone in the field.
Okay, so given this vast and evolving landscape, one might think tracking these conditions would be straightforward. But you're saying it's not. What makes accurately documenting the true incidence and prevalence of aortic disease such a significant challenge?
Yeah, that's where the elusive nature of diagnosis really comes into play. Firstly, and tragically, some patients may succumb to aortic processes, or sometimes other severe, often undiagnosed diseases, before a definitive diagnosis of their aortic condition is ever actually made. So the cause of death might be attributed to something else, or they simply pass away before an investigation can pinpoint the aortic issue.
Which implies we're likely undercounting. Right. And then there's the flip side. Aortic pathology is frequently discovered incidentally. Someone might be getting an imaging scan for something totally unrelated, say a persistent cough or maybe some back pain, and suddenly, boom, a major aortic problem is revealed.
Precisely. And adding to this challenge is that aneurysmal disease, which is a major category we'll definitely get into, is typically asymptomatic. You heard that right, it often doesn't cause any symptoms unless it's growing rapidly, maybe associated with inflammation, a condition known as aortitis. Or, in the most dire circumstances, it ruptures. It's like having a ticking time bomb that often gives absolutely no warning until it's potentially too late.
That's a truly frightening thought. And it gets even more complicated when you consider that the very definition of what constitutes an aneurysm can sometimes be a point of debate among clinicians. It's not always a clear-cut line.
You're exactly right. Precision is paramount in medicine, obviously, and these kinds of ambiguities make collecting accurate epidemiological data really difficult. Furthermore, aortic dissection, or AD, another critical condition, may unfortunately first be recognized only at autopsy. That really highlights the extreme diagnostic challenge when the patient never received a diagnosis while alive. And finally, aortic disease might just be one component of a broader systemic illness, with the diagnosis only made after preventative measures aren't applicable anymore, meaning the disease has progressed significantly. It paints a picture of, well, a silent, insidious threat that's often discovered late in the game.
It certainly does. But despite this tendency for aortic disease to present late, we're in a remarkable era now. A wide array of both surgical and medical therapeutic options, management options, are now available. That represents a true paradigm shift in treatment, doesn't it? This is where the hope really lies for patients.
Absolutely. The introduction of endovascular approaches to both the thoracic and abdominal aorta has dramatically expanded operative therapy to patients who were previously, frankly, deemed inoperable. Think about that. Individuals who once had no options now have a potential lifeline thanks to these less invasive techniques. It truly is a revolution in patient care.
But this doesn't mean open surgery is obsolete, does it? It's not like it's gone away.
Not at all, no. It's crucial to understand that open surgery remains an absolutely vital part of the surgeon's armamentarium, their comprehensive set of tools and techniques. It's not one replacing the other entirely, but rather complementing it. We're also seeing the merging of these techniques, these hybrid approaches, which have become quite common. This adaptability within modern surgical practice allows for highly tailored and often superior patient solutions.
And beyond the operating room, medical management retains a crucial, often foundational role. Advances in genetic testing, for instance, have enabled earlier diagnosis for some conditions, allowing for more proactive care, right?
Exactly. And that early diagnosis can lead to targeted therapies. For example, angiotensin II receptor blockers are used for managing Loeys-Dietz syndrome, and beta blockade is really a cornerstone for managing aneurysmal disease. Now, these aren't cures, but they aim to control the growth and prevent rupture, which is absolutely vital. The synergistic application of medical and surgical approaches really underscores the comprehensive nature of modern aortic care.
Okay, let's shift our focus now to the very blueprint of the aorta, starting with its fascinating, maybe somewhat complex embryological formation. This journey from embryo to organ holds the keys to understanding the variations we see later on.
Indeed. The development of the aorta and its major branches begins remarkably early in the third week of gestation. This highly intricate developmental process inherently leads to the structural and histological variants we observe in individuals. It starts with paired right and left ventral and dorsal aorta. Over a short period, the two ventral pairs fuse to form the aortic sac that eventually contributes to the ascending aorta, while the dorsal pairs fuse to form the descending thoracoabdominal aorta.
And then come the pharyngeal arches, or arch arteries, forming in weeks 4 and 5.
Yeah.
What's truly fascinating, as you mentioned in the outline, is how they develop head to tail, but then regress in the opposite order. And they're not even all present at the same time. It's a fleeting but really impactful stage.
It truly is. These 6 corresponding aortic arches form from the aortic sac, ending on the dorsal aortae, but they start to regress around day 27 of gestation and are completely gone by day 29. Their remnants, however, contribute directly to the normal adult aorta, and the specific patterns of their persistence and regression are absolutely crucial for understanding anatomical variations later on.
That process of selective persistence and regression is exactly what Edwards' theoretical arch helps to explain, right? He proposed this brilliant concept of a theoretical double aortic arch system.
It's a really elegant model. Edwards pictured the developing aorta as consisting of bilateral arches and ductus arteriosi that encircle both the trachea and the esophagus. By considering which specific segments persist and/or regress from this theoretical double arch, his model can describe the majority of arch and aortic anomalies we see clinically.
So it's like a developmental choose-your-own-adventure, where tiny shifts lead to different anatomical outcomes. Can you give us a concrete example?
Certainly. For instance, the development of the normal left-sided aortic arch, which most of us have, requires the regression of a specific segment, segment 1 in Edwards' model. If segment 4 regresses instead, you get a variant right-sided aortic arch. If segment 2 regresses, you end up with a left-sided arch but with an aberrant right subclavian artery, meaning it takes an unusual path. And conversely, regression of segment 3 results in a right-sided arch with an aberrant left subclavian artery. This model just beautifully clarifies how these congenital variations arise from seemingly small developmental shifts.
That makes a lot of sense. Now, moving from development to the adult structure, describing the aorta anatomically can still be, well, perplexing due to various overlapping naming systems. These systems are based on both normal anatomy and pathological conditions.
Right. To bring clarity, we use well-defined landmarks to subdivide the aorta into specific anatomical segments. Starting from the heart, we have the aortic root. This begins at the aortic valve annulus and extends up to the sinotubular junction. It traditionally includes the aortic valve itself, and embryologically, it derives from the truncus arteriosus.
Okay, then continuing from the sinotubular junction is the ascending aorta.
Correct. It extends to either the takeoff of the innominate artery or the pericardial reflection. Like the root, it also originates embryologically from the ventral aorta. Distally, the ventral aorta bifurcates into two horns during development. The right becomes the brachiocephalic artery, and the left forms the proximal part of the aortic arch.
Then comes the aortic arch itself, that critical curved segment.
Exactly. It starts at the end of the ascending aorta and finishes just distal to the left subclavian artery, the SCA. Interestingly, the remnant of the fourth embryologic aortic arch forms the specific portion of the aortic arch between the left common carotid and the left SCA. After the arch, we move into the descending thoracic aorta, which begins just distal to the left SCA and extends down to the aortic hiatus, that opening in the diaphragm.
And finally, past the diaphragm, we hit the abdominal aorta.
That's right. The abdominal aorta begins at the aortic hiatus and then transitions into the suprarenal aorta above the renal arteries, and then the infrarenal aorta below the renal arteries. The terms juxtarenal or pararenal are usually reserved for describing disease segments in these areas, not necessarily the normal anatomy itself. It highlights that distinction between anatomical description and pathological classification.
So that's the normal anatomy laid out. But then we have these specific pathologic classifications, which provide a kind of roadmap for understanding different disease states. Let's start with aneurysmal disease.
Aneurysmal disease nomenclature is probably the most straightforward. It's typically labeled just by location, like root aneurysm or arch aneurysm, though, as always, there are important exceptions. For instance, Estrera and colleagues subdivide the descending thoracic aorta into type A, B, and C based on their proximity to the sixth rib. Now, this isn't just an academic exercise. This classification has significant implications for the risk of postoperative paraplegia, a really serious complication. So it's vital for surgical planning and talking to patients.
And for the endovascular surgeons, the Society for Vascular Surgery, the SVS, divides the aorta into zones, specifically zones 0 through 4. What's the purpose of those?
Those zones are absolutely crucial for planning endograft attachment sites in endovascular repair. They tell surgeons exactly where they can safely land and seal a graft. It's less about describing the overall extent of the disease itself. Now, for thoracoabdominal aortic aneurysms, or TAAAs, the Crawford classification is paramount. Refined by Crawford and his colleagues, this system categorizes aneurysms based on the extent of both thoracic and abdominal involvement.
And the terminology evolved over time, right? From group to extent or type. What were the original extents and how did they change?
Yeah, the original classifications included extent I, that involved the descending thoracic and abdominal aorta up to the celiac artery. Extent 2, which involved the entire thoracic and abdominal aorta of very extensive and challenging repair. Extent 3, described as less thoracic involvement in most of the abdominal aorta. Extent 4 involved the entire abdominal aorta, and an original Extent V, which involved the lower abdominal aorta and renal arteries. This was later refined down to 4, then eventually 5, extents to specifically account for aneurysms involving only a portion of the thoracic aorta while sparing the infrarenal aorta. The Crawford classification remains an absolutely vital tool for comparing procedural outcomes in TAAAs. It allows surgeons to standardize reporting and compare results across different centers globally.
Okay, that covers aneurysms pretty well. Now, let's move to aortic dissection, or AD. This has its own crucial classification schemes for guiding clinical decisions. The DeBakey classification was the pioneer here, wasn't it? Trying to distinguish where the dissection was limited.
Indeed. DeBakey type I involved the entire ascending aorta, the arch, and to some extent the descending aorta. This typically points toward surgical management. Type 2 is limited just to the ascending aorta, also generally indicating surgery. Type 3 is a dissection of the descending aorta alone. Historically, this implied non-surgical management initially. It's further subdivided into IDEA, where the tear is only in the descending thoracic aorta, and API, where the tear extends below the diaphragm.
And then we have the Stanford classification, which feels a bit simpler, maybe more practical for quick decisions.
It is more limited, yes, but highly practical for those initial management decisions. Type A encompasses dissections with any involvement of the ascending aorta. That broadly dictates surgical management. Type B is for dissections distal to the left subclavian artery, which broadly suggests medical management first. Now, the landscape is definitely shifting with endovascular therapy, moving type B dissections towards more interventional approaches, but the Stanford classification still provides immediate information on the disease extent that's relevant to those initial critical decisions.
And beyond just acute versus chronic, there are more granular time domains for dissections now. Is that correct?
Yes. While the classical separation between acute and chronic is often cited at the 2-week mark, a recent modification introduces 4 more granular time domains. Hyperacute, less than 24 hours, acute, 2 to 7 days, subacute, 8 to 30 days, and chronic, more than 30 days. This allows for a more nuanced understanding of how the disease is progressing and helps guide treatment timing. It's fascinating that both DeBakey and Stanford classifications conveniently sort of ignore dissections that begin or are limited just to the aortic arch itself. Landsman and colleagues expanded on Stanford specifically to include arch dissections, noting that a significant percentage, maybe 30% of type A dissections, actually have arched ears. These were associated with a non-statistically significant decrease in 10-year survival. This just highlights the ongoing refinements needed in classification.
And the European Society of Cardiology, the ESC task force, proposed an entirely different classification system based purely on the anatomic presentation.
Yeah, a very different approach, focusing on the pathology itself. Class 1 is classic AD with a distinct intimal flap. Class 2 is intramural haematoma, IMH. Class 3 is a subtle or discrete AD. Class 4 is a penetrating atherosclerotic aortic ulcer, PAU. And Class 5 is iatrogenic or traumatic dissection, meaning caused by medical procedure or injury. For our deep dive today, consistent with the textbook chapter, we'll consider traumatic dissection, transection, IMH, and PAU as separate non-dissection processes, although they are part of the broader acute aortic syndrome spectrum. We'll discuss them distinctly later on.
That's a crucial distinction. And more recently, the Penn classification scheme offers a highly practical approach. It sounds like it combines the Stanford classification, the DeBakey dissection extent, and adds a critical distinction focus on clinical presentation and, importantly, distal malperfusion.
Exactly. It synthesizes the best of both worlds, adding those real-world clinical consequences. It was initially developed for type A aortic dissection, TADE. Its subgroups are Penn Class A, absence of branch vessel malperfusion or circulatory collapse; Penn Class AB, branch vessel malperfusion with ischemia; Penn Class A, circulatory collapse with or without cardiac involvement; and Penn Class ABC, which is, you guessed it, both malperfusion and collapse. The core rationale for this approach was a deep appreciation of the consequences of malperfusion, that lack of blood flow on patient interventions, prognosis, and overall outcomes.
And it was modified for type B dissection as well.
Yes, to better differentiate between complicated and uncomplicated type B dissection. Class A signifies the absence of branch vessel malperfusion or circulatory collapse, and it's further subdivided into type I, high risk for future aortic complications, and type 2, low risk. Class B is branch vessel malperfusion with ischemia. Class C is circulatory collapse, subdivided into type I for aortic rupture with hemorrhage outside the wall, and type 2 for threatened aortic rupture. And finally, Class BC encompasses both malperfusion and circulatory collapse. This level of detail truly helps clinicians triage patients and plan treatment with much greater precision.
Okay, now let's turn our attention specifically to aneurysmal disease itself. At its most basic level, what exactly is an aneurysm?
At its core, an aneurysm is typically defined as an increase in the arterial diameter of more than 50% above the normal size for that segment. And they can occur anywhere along the aorta, from the aortic root right at the heart, all the way down to its bifurcation in the lower abdomen. However, it's really critical to understand that the mean or average aortic diameter differs significantly between the ascending, the descending, and the infrarenal aorta. So the absolute size criteria for what actually constitutes an aneurysm changes depending on the specific segment you're looking at. Normal values also vary due to measurement methods, patient age, sex, and other factors too.
Can you give us an example just to illustrate this variability in what's considered normal?
Sure. A population-based MRI study of 70-year-olds by Wanhanen and colleagues defined aneurysms as 4.7 centimeters in men and 4.2 centimeters in women for the ascending aorta, 3.7 centimeters in men and 3.3 centimeters in women for the descending aorta, and 3.7 centimeters in men and 2.7 centimeters in women for the infrarenal aorta down low. This really highlights how precise these definitions can become and how they vary even by gender and location. So when we talk about an aneurysm, it's definitely not a one-size-fits-all number. It's about knowing your baseline and understanding that even seemingly small changes can be significant in different parts of this vital vessel.
Beyond just size, how are aneurysms anatomically characterized? What do they look like?
Anatomically, we generally describe them as either fusiform or saccular. Fusiform aneurysms show a smooth circumferential dilatation across the entire vessel, kind of like a symmetrical bulge or spindle shape. In contrast, saccular aneurysms appear as a focal outpouching of the arterial wall, more like a bubble or a sac sticking out to one side.
And there's also an important distinction between true and false aneurysms, or pseudoaneurysms, correct? What's the difference there?
That's a very important distinction, yes. True aneurysms involve all three layers of the vessel wall: the intima, inner, media, middle, and adventitia, outer. The vast majority of aneurysms we discuss here are degenerative in nature, meaning they result from wear and tear over time, essentially. A false aneurysm, or pseudoaneurysm, describes a focal defect in the artery, where the collection of blood is contained only by the surrounding connective tissue, not all three wall layers. These can be degenerative, infectious. Those are known as mycotic aneurysms or traumatic in origin. They might also occur at sites of prior surgical anastomosis, representing a disruption of that connection point. Less frequently, aneurysms can also be associated with inflammation or autoimmune connective tissue diseases, which require special consideration in their evaluation and management, as the underlying cause will definitely dictate different treatment approaches.
So what actually causes this aneurysmal enlargement? It sounds like it's probably a combination of factors working together.
You're right, it's definitely a multifactorial view. The core mechanism is associated with factors that lead to weakening of the arterial wall and, at the same time, increased local hemodynamic forces, essentially, the forces of blood flow pushing on a weakened vessel wall. Genetic predisposition plays a significant role. We see heritable conditions like Marfan syndrome, that's a mutation of the FBN1 gene, familial thoracic aortic aneurysm and dissection, and vascular type Ehlers-Danlos syndrome. There are also less well-defined genetic entities that significantly contribute to the elevated incidence of aneurysm in patients who have a family history of the condition.
So if it runs in the family, the risk is definitely higher. What about at the microscopic level, happening within the vessel wall itself?
Well, factors contributing to the degradation of the extracellular matrix, that's the scaffolding around the cells, and a reduction of elastin concentration, which is a key protein for arterial elasticity, are strongly associated with aneurysmal disease. Research in this area has particularly focused on the role of matrix metalloproteinases. Those are enzymes that break down matrix components, both their presence in aneurysm specimens and also deficits of the antiproteolytic enzymes that normally inhibit them. Current avenues of investigation also include the complex roles of the immune response and the hormonal environment in the body. And finally, aneurysmal dilatation can also occur as a degenerative complication after an aortic dissection has already happened, highlighting how interconnected these different aortic pathologies can be.
Given all this complexity, determining the true incidence and prevalence is difficult, as we noted earlier. But what are the known risk factors for these conditions, particularly for abdominal aortic aneurysms, AAAs? Who's truly at risk?
The asymptomatic nature of aneurysms, often found incidentally, certainly complicates getting accurate incidence data. However, large screening studies estimate AAA incidence somewhere between 3% to 10% in the general population. Key risk factors for AAA development include tobacco use, that's a big one, hypercholesterolemia, hypertension, being male, and having a family history. For AAA expansion, we see factors like advanced age, severe cardiac disease, a previous stroke, and again, tobacco use, where interestingly, the duration of smoking seems more impactful than the amount smoked per day. Cardiac or renal transplantation also increase the risk of expansion.
And for the most critical outcome, rupture. What increases that risk?
Rupture risk factors include being female, having reduced FEV1, which indicates lung issues, a larger initial abdominal aortic diameter, higher mean blood pressure, current tobacco use, and that critical relationship between wall stress and wall strength. On the flip side, female gender, black race, and diabetes actually appear to be protective against AAA development. Interestingly, recent studies suggest that in first world countries, the incidence of AAA has actually been decreasing over the past 2 decades. This is most likely related to the decreased tobacco burden in those countries, which really underscores the significant impact of public health measures.
What about gender differences in AAA beyond just incidence? You mentioned females have a higher rupture risk.
Yes, the differences extend to presentation, associations, and natural history. Men with AAA are more likely to present with concurrent iliac or femoral popliteal aneurysms further down the leg. Women, unfortunately, are more likely to experience rupture and consistently demonstrate poorer outcomes after repair. This might be because women often present with significantly more challenging anatomy, making surgical repair inherently more complex. In the specific at-risk populations we screen, like the 65 to 89-year-old demographic, AAA incidence is around 5% to 7%, with a male-to-female ratio of roughly 4 to 1. Now, for thoracic aortic aneurysms, TAAs, the estimates are around 400 per 100,000 patients in 65-year-olds and 670 per 100,000 in 80-year-olds. But in contrast to AAA, there does not appear to be a gender difference for TAAs.
Okay, so aneurysms are often asymptomatic, but when they do speak, so to speak, what are the signs and symptoms we should be aware of?
Well, while aneurysms can be silent for long periods, an acutely enlarging or inflamed aorta may present with pain. This is a critical symptom indicating potential danger and should prompt immediate medical attention. Depending on the aneurysm's specific location, other less common signs or symptoms can occur due to compression of the surrounding structures. For example, an enlarged ascending aorta or proximal arch can impinge on the superior vena cava, leading to superior vena cava syndrome, that's swelling of the face, neck, and arms.
And what about effects on the voice or even breathing? Can that happen?
Yes, an expanding proximal descending aorta can impinge on the left recurrent laryngeal nerve, causing hoarseness that's known as Ortner syndrome. Extrinsic compression of the left main stem bronchus by a large descending aneurysm can also lead to pulmonary embarrassment or difficulty breathing or lung issues. And for abdominal aortic aneurysms, AAAs, really large ones may cause a feeling of fullness or early satiety, even after small meals, just due to compression within the abdomen. These less common symptoms are really crucial clues for clinicians to pick up on.
So how do doctors actually peer inside the aorta and diagnose these conditions? What are the main diagnostic tools used today?
Okay, starting with the basics, a chest X-ray, CXR, might incidentally detect a thoracic aneurysm because of abnormalities in the aortic contour size or maybe calcifications. But it is not considered a good screening tool for aortic disease. It's often just a lucky find. Ultrasound US is an important, non-invasive, and cost-effective tool, particularly in AAA management, and it's known for its accuracy. Its utility is further enhanced with contrast-enhanced ultrasound, which is especially useful in patients after endovascular aneurysm repair, EVAR, for detecting, localizing, and quantifying endoleaks, those leaks within the repair site.
And echocardiography, which is ultrasound specifically at the chest area.
Right. Transthoracic echocardiography, TTE, is non-invasive and useful for measuring certain segments of the ascending aorta and also assessing the degree of aortic valve insufficiency, if it's present. For a more detailed view, there's transesophageal echocardiogram, TEE, which is an invasive technique. It can visualize the thoracic aorta from the aortic annulus, the valve base, all the way down to the celiac axis in the abdomen, with the exception of a short blind spot segment of the ascending aorta proximal to the innominate artery. This technique usually requires at least a modest level of sedation for the patient. There's also intravascular ultrasound, IVUS, another modality which is invaluable as an adjunct during endovascular procedures, providing real-time imaging from inside the vessel itself.
And the current gold standard for many situations, computed tomography or CT.
Yes, CT provides excellent imaging of the aorta. It offers greater reproducibility of diameter measurements compared to ultrasound, making it a really vital tool in the diagnosis, management, and surveillance of aortic disease. When iodinated contrast agents are used, it becomes CT angiography, CTA. CTA provides a wealth of anatomical information, including detection of vessel calcification, thrombus, which are blood clots, and any concurrent arterial occlusive disease. It also permits multiplanar and three-dimensional reconstruction and analysis, which is absolutely crucial for operative planning. However, the drawbacks include substantial radiation exposure, particularly in the setting of serial examinations for surveillance over time. Also, the use of iodinated contrast media carries risks, especially in a population that often has a high incidence of comorbid kidney disease.
So what's a good alternative to CT for some patients, especially to avoid that radiation exposure?
Magnetic resonance imaging, MRI, offers a reasonable alternative, particularly beneficial because it eliminates ionizing radiation and the need for iodinated contrast. Certain sequences like spin echo, black blood, and gradient echo provide an intrinsic contrast between the blood flow and the aortic wall, offering detailed dimensional and geometric information. With intravenous gadolinium contrast, magnetic resonance angiography, MRA, provides rapid 3D imaging of the aorta without needing electrocardiogram, ECG gating. What's truly exciting is the ability to acquire dynamic images throughout the cardiac cycle. This allows physiological parameters like estimates of wall shear stress to be determined, which may lead to really interesting future clinical applications. However, MRI doesn't show aortic wall calcification, which can be important in operative planning, especially for endovascular approaches. While MRI avoids iodinated contrast, it uses gadolinium, which has been associated with nephrogenic systemic fibrosis in patients with low kidney function, glomerular filtration rate. Also, a contraindication for MRI is the presence of incompatible metallic implants or foreign bodies, although many mechanical valves, pacemakers, and defibrillators marketed now in the US are often MRI compatible. Newer ferrous-based contrast agents coupled with MRA might provide a viable alternative for vascular imaging when both iodinated contrast and gadolinium are contraindicated.
Okay, so beyond surgery, what role does medical management play for these aneurysms?
Medical management is a crucial mainstay, especially for aneurysms that don't meet the criteria or appropriateness for surgical intervention. Size and symptoms play a large role here, obviously. Lifestyle modifications are absolutely foundational. Tobacco cessation is paramount. Current smoking has been significantly associated with increasing the expansion rate of abdominal aortic aneurysms, AAAs, by approximately 0.4 millimeters per year. Quitting directly impacts progression.
And what about exercise? Can patients with aortic pathology exercise safely?
Well, while moderate levels of exercise definitely have a beneficial impact on a patient's cardiopulmonary health and the progression of atherosclerosis, patients with aortic pathology should generally avoid vigorous levels of activity and contact sports. Activities that cause a sudden spike in blood pressure may lead to aortic rupture or dissection in the presence of that underlying aortic pathology. Blood pressure management is obviously key, often requiring multiple medications. The dual goals are reducing systolic pressure and also pulse pressure, which is an indirect measure of DPDT, or the rate of pressure change over time, and wall stress, basically the force hitting the aorta wall. Beta blockers, both selective and non-selective, are particularly useful in accomplishing both of these goals.
Is the goal just to slow the enlargement, or can we actually prevent or even reverse it with medication in some cases?
Well, an ideal consequence of medical therapy would certainly be the prevention of aneurysmal dilatation or even regression of existing aneurysms. This has actually been shown to be the case in the specific clinical scenario of patients with Marfan syndrome treated with beta blockers, angiotensin, the second receptor blockers, and angiotensin-converting enzyme ACE inhibitors. Unfortunately, none of these drugs has been shown to be effective in patients who do not have Marfan syndrome, highlighting the very disease-specific nature of treatment effectiveness. However, statin therapy, HMG-PCoA reductase inhibitors, has been associated with reduced rates of AAA enlargement. It's also generally appropriate in this population, which has a high prevalence of concurrent atherosclerotic disease anyway. Statin therapy has been shown to improve survival following both open and endovascular repair of AAAs and to decrease the incidence of major cardiovascular events like stroke, myocardial infarction, and death for patients diagnosed with AAA. Finally, antiplatelet therapy using aspirin offers a secondary preventative benefit in this patient population as well.
So medical management is definitely a big part of the picture. But how do we catch these aneurysms early in the first place, and how do we monitor them closely over time? What are the current screening and surveillance recommendations?
Screening recommendations are informed by several things: the sensitivity and specificity of ultrasound screening or other imaging, the detection yield of screening based on various risk factor selection criteria, and of course, cost is always a factor. For thoracic aneurysms, as a general rule, screening is generally not done without a pre-test high probability, for example, a strong suspicion of an aortic syndrome. The crucial caveat here, though, is that when an AAA is diagnosed, it is a general recommendation that the thoracic aorta be screened as well to rule out metasynchronous disease, that's another aneurysm occurring at a different site.
Find one, look for another. Got it. What about the current consensus guidelines specifically for AAA screening?
They generally recommend one-time screening of all men aged 65 years and older, or men 55 years and older who have a family history of AAA. The U.S. Preventive Services Task Force, USPSTF, issued a more limited recommendation back in 2014 for one-time screening for AAA using ultrasonography just for men between 65 and 75 years of age who have a personal smoking history, and selective screening for non-smokers.
What about women? This seems to be a particularly controversial area for screening.
It absolutely is. Recommendations for women remain highly controversial. The USPSTF concluded there was insufficient evidence to recommend routine screening in women who smoke and actively recommended against routine screening in non-smoking women. One significant issue that may have biased these results is the paucity of women included in the large screening trials. For example, in one meta-analysis that looked at a combination of 4 studies with over 125,000 patients enrolled, less than 10,000 subjects were women. That's a clear gap in the data. Payer policies regarding reimbursement, like Medicare, may not strictly track either of these recommendations. Medicare, for instance, due to the screening abdominal aortic aneurysms very efficiently, SAAV Act, reflects an intermediate approach. It offers a screening benefit for men with a personal smoking history and men or women with a family history of AAA, though only as part of the initial Welcome to Medicare physical examination. And tragically, a single institution study looking at ruptured AAAs shockingly demonstrated that only 17% of those patients would have been eligible for screening based on current criteria prior to their rupture. That highlights a very significant diagnostic gap in our current practice.
That's a powerful reminder of how many people might be slipping through the cracks. For those non-surgical aneurysms that are detected, regular surveillance is necessary, right? How does that work?
Yes, absolutely. Following the initial detection of a non-surgical aneurysm, regular surveillance is necessary in addition to optimal medical management. Ideally, surveillance should be low cost, high sensitivity, and pose minimal harm to the patient. For the abdominal aorta, ultrasound follow-up is generally advisable. Patients with a known AAA who do not undergo appropriate surveillance may face up to a 6-fold increase in the rate of rupture, a massive jump in risk.
The Society for Vascular Surgery, SVS Clinical Practice Council, has specific screening intervals based on the maximum external aortic diameter and the associated rupture risk. Can you outline those?
Sure. For an aorta diameter less than 2.6 centimeters, no further screening is generally recommended, although some have suggested 3 centimeters as the cutoff. For 2.6, 2.9 centimeters, re-examination at 5 years is suggested. Though countering the no further screening for 2.6 centimeters, it's noteworthy that a significant proportion, almost 14%, of 65-year-old men with an initial aortic diameter of 2.6 to 2.9 centimeters developed aneurysms exceeding the 5.5 centimeter surgical threshold at 10 years. It suggests normal now doesn't necessarily mean normal forever. For 3.4 centimeters, re-examination at 3 years. For 3.5, 4.4 centimeters, re-examination at 12 months. And for 5.4 centimeters, re-examination at 6 months. These recommendations, similar to those for thoracic aortic aneurysms, stem from our understanding of the growth rates of normal and abnormal aortas, as well as published rates of rupture at given sizes. However, it's important to note that no large prospective studies directly comparing different surveillance intervals currently exist. Given current life expectancy projections, it's evident that a subset of patients deemed normal at initial screening will unfortunately go on to develop clinically significant aneurysms, emphasizing the ongoing need for vigilance.
And what about thoracic aorta surveillance? Is it as straightforward as using ultrasound?
It's often considered more art than science. With the exception of the aortic root, which is visible with TTE, the thoracic aorta generally requires CT or MRI contrast imaging for effective surveillance. After the initial diagnosis, a second study at 6 months should usually suffice to determine if there is measurable growth in the aortic diameter. This is then typically followed with yearly scans until there is reasonable certainty of size stability, at which point expending surveillance to maybe a 2 to 3 year interval is tolerable. Converting to MRI for surveillance helps avoid exposing the patient to cumulative ionizing radiation over many years.
So the primary rationale for all this surveillance imaging is clearly rupture prevention. Right. Do risk models for rupture exist to help guide decisions beyond just size?
Yes, they do. Yuvonen and colleagues developed a model that included risk factors of age, presence of pain, chronic obstructive pulmonary disease, COPD, and the maximal diameters of both the thoracic and abdominal aorta. Based on this model, surgery was recommended when the calculated risk of rupture within 1 year exceeded the anticipated mortality risk of an elective procedure, even if the generally recommended aortic diameter for intervention had not yet been reached. This raises a really important question. Should we always adhere strictly to size guidelines, or can risk prediction models like this help refine our approach and personalize care even further?
That's a great provocative thought. Let's talk about the actual outcomes of aneurysm repair. open, endovascular, and the hybrid future. What influences these outcomes significantly?
Outcomes for surgical intervention are highly dependent on the location of the lesion, the extent of the disease, and of course, the technique of repair employed. Endovascular technology has had a dramatic impact on treatment options and outcomes, no doubt, but open repair or hybrid approaches remain a really important part of the surgeon's capabilities. For aneurysms involving the aortic root and ascending aorta, when repaired electively, the mortality rate is approximately 5% for all patients, and likely even less when performed in high-volume centers with specialized expertise. For arch aneurysms, when they involve the arch, the mortality outcomes are similar to those for the ascending aorta. But there is an increase in morbidity, specifically with cerebrovascular injury like stroke, highlighting the delicate nature of operating in this anatomical area.
For the descending thoracic aorta, it seems TEVAR, that's thoracic endovascular aortic repair, has largely become the standard of care for most aneurysmal disease there.
Yes, that's generally true. Since the first reported series by Dake and colleagues back in 1994, the indications for TEVAR have significantly expanded. While there's a relative paucity of randomized controlled studies directly comparing TEVAR to open repair of descending thoracic aortic aneurysms, a meta-analysis of 42 non-randomized studies involving almost 6,000 patients demonstrated a reduction of all-cause mortality and paraplegia, as well as a decrease in other complications and length of hospital stay with TEVAR. However, beyond 1 year, there was no significant difference found in mortality or the need for surgical reintervention, suggesting maybe a long-term equivalence in some aspects between the two approaches.
What about thoracoabdominal aortic aneurysms, TAAAs? You mentioned these are complex. Are there endovascular devices approved for these cases in the U.S. yet?
No, not currently approved for general use in the United States. This means open surgery remains the mainstay of treatment for TAAs. Recently reported surgical mortality has ranged from 2.3% to 7.5% in highly specialized centers, but it can exceed 20% in real-world practice outside those centers, really emphasizing the complexity and risk involved. A meta-analysis demonstrated a pooled mortality rate of 11.26%, with Crawford extent 2 stake AAs, those involving the entire thoracic and abdominal aorta having the highest risk of death. And pooled spinal cord ischemic rates leading to paraparesis or paraplegia were estimated at 8.26%. Successful repair is highly reliant on a cohesive team approach, including cardiothoracic and or vascular surgeons, cardiac anesthesiologists, specially trained nursing staff, and intensivists who are knowledgeable of the nuances and subtleties required for caring for this incredibly complex patient population. It truly takes a village.
Let's move down to infrarenal abdominal aortic aneurysm per DA repair. What are the typical outcomes for open repair here?
Reported outcomes for open abdominal aortic repair vary quite a bit, from 1% to 4% for infrarenal repair performed in centers of excellence, up to 4% to 8% noted in statewide or nationwide databases. Complications associated with open repair occur in about 15% to 30% of patients. Both early mortality and complication rates are generally better with an endovascular approach, EVR to AAAs, though this may represent some selection bias. Perhaps healthier patients are more often chosen for EVA. The landmark United Kingdom EVAR trial randomized over 1,200 patients with AAAs larger than 5.5 centimeters for elective open repair versus EVAR. While the 30-day mortality rate was favorably lower for EVAR, 1.8% was 4.3%, statistically significant difference. This benefit was actually lost by the end of the study. Additionally, EVAR was found to be more costly, partly due to increased rates of graft-related complications and the need for reintervention over time.
So an early win for EVAR in that trial, but then it seemed to even out over the longer term. Is that finding replicated in other studies?
Yes, a similar study by the Dutch randomized endovascular aneurysm management DREAM trial group found that the early advantages of EVAR had also disappeared by the 2-year follow-up mark. So what this all means for the long-term outlook is that while EVAR offers significant short-term advantages, like quicker recovery and lower initial mortality, the long-term outcomes for overall mortality and the need for further procedures can be comparable to open surgery. This really underscores the nuanced decision-making required for each patient.
Let's talk more about endovascular aneurysm repair, EVR itself, its feasibility and the challenges involved.
Okay. With currently approved and available technology, roughly 80% of non-emergent AAAs can be repaired using an endovascular approach, which showcases its broad applicability now. However, accurate evaluation of the patient's anatomy is absolutely essential for considering an endovascular approach. This includes looking at the neck of the aneurysm, which must be of sufficient length without severe angulation, extensive mural thrombus, that's blood clot lining the wall, or significant calcification. The diameter of the proximal seal zone must also not be too large to prevent a secure proximal seal. Furthermore, the access vessels, usually the iliac and femoral arteries, must be of sufficient diameter to allow safe passage of the appropriately sized sheaths and delivery devices.
So anatomy is absolutely key for EVR. But as the devices themselves evolve, are the anatomical indications expanding? Can more people get EVR now?
Yes, definitely. As newer generation devices have become available, the anatomical indications for EVA have expanded. AAAs with necks as short as 4 millimeters long can now potentially be treated with custom-made fenestrated stent grafts or with suprarenal fixation devices and endo anchors. Many aortoiliac aneurysms can also be treated with iliac branch devices. Arteriotomy closure devices have allowed many aneurysms to be safely repaired with a totally percutaneous approach, meaning no large incision is needed for access. While post-procedure pseudoaneurysms are maybe a bit more common with these arteriotomy closure devices, there are fewer seromas, wound adhesences, and surgical site infections associated with their use. And on the horizon are branched endografts designed to treat perirenal or even TAAAs, though as we mentioned, these devices are not yet available for general use in the United States. Open surgery remains the standard for those very complex cases for now.
What about after EVA? Is ongoing surveillance necessary? You mentioned it briefly before.
Absolutely. Postoperative evaluation of a successful EVR includes serial CT scans and/or color duplex ultrasonography. We're specifically looking for changes in the aortic sac diameter or volume, any graft migration, and crucially, endoleaks. Surveillance imaging is generally recommended at 1 month, 6 months, 12 months, and then yearly thereafter, provided the exam remains stable. This need for ongoing surveillance means that patients who may be unwilling or unable to undergo regular postoperative imaging may not actually be appropriate candidates for EVR because that strict follow-up is absolutely critical for long-term success and safety.
And what exactly are endoleaks? They sound like a major potential complication to watch out for after EVR.
They are. When identified, endoleaks are classified into 5 types. Type 1A is leakage at the proximal seal zone, right at the top. Type 1B is leakage at the distal seal zone, at the bottom. Type 2 is retrograde flow, meaning backward flow, from lumbar arteries and the inferior mesenteric artery back into the aneurysm sac. These are actually quite common early after EVR, and most resolve spontaneously within 1 to 6 months. Management of persistent type 2 endoleaks is controversial, with most favoring observational management if the sac isn't growing. However, if sac growth does occur after EVAR with an otherwise stable type 2 endoleak, a delayed type 1 or type 3 endoleak might be the underlying culprit, requiring further investigation. Type 3 is linkage due to component separation, for example, a disconnection between modular graft components. Type 4 is leakage due to fabric porosity, basically blood seeping through the graft material itself. And type 5 is an expanding aneurysm sac without any demonstrable blood flow, sometimes called endotension, indicating there's still persistent pressure on the soil. Importantly, type 1 and type 3 endoleaks typically require repair because they involve direct pressure transmission into the aneurysm sac, posing an immediate risk of rupture.
So when anatomical considerations fall outside the specific instructions for use for the available endovascular devices, open repair remains the most acceptable treatment option.
Precisely. Additional potential considerations that might favor open repair include younger patients, patients with known connective tissue disorders like Marfan syndrome, where the tissue quality can affect graft materials and fixation, and, as we discussed, those individuals who are unable or unwilling to participate in the necessary lifelong post-operative surveillance regimen. Now, for patients whose comorbidities would exclude open repair but who are also not standard EVR candidates due to anatomy, novel approaches to endovascular repair have been described. These options may include things like snorkel chimney EVR, using covered stents as chimneys alongside the main graft to preserve branch flow, physician-modified endografts, and the use of investigational devices not currently available for widespread clinical use in the United States. These advanced options necessitate specific local expertise and may require federally approved individual device exemption, IDE, prior to proceeding.
Let's specifically talk about ruptured abdominal aortic aneurysms, RAAAs. This is clearly an urgent, life-threatening challenge.
Ruptured AAAs absolutely deserve special attention due to their dire nature. Approximately 15,000 annual deaths from ruptured AAAs occur just in the United States, making it a really significant public health concern. Now, in ruptured AAAs, where it would seem ideal to treat with an endovascular approach if possible, there has actually not been any statistical evidence of a short-term benefit of one approach versus another, EVAR versus open, One European trial comparing open and EVAR for RAAA found no difference in operative mortality, 39%, 35% respectively, or 90-day mortality, 42%, 40%. The IMPROVE trial, immediate management of the patient with ruptured aneurysm, open versus endovascular repair, also found no difference in 30 or 90-day mortality. However, there was an advantage seen for EVAR at 3 years, 42% mortality versus 54% for open, but interestingly, this advantage was gone by 7 years.
That's complicated to interpret, isn't it? Similar to the elective trials.
It is very challenging. Interpreting these trials is difficult because the intention to treat, meaning the treatment that was planned and the treatment received, may not always align, which can potentially bias the conclusions. Post hoc analysis of these data, looking back, suggests that those patients who were actually able to receive an endovascular repair did enjoy better outcomes. Therefore, it is the recommendation of many experts to consider an endovascular first approach, where it's feasible, given the potential for better outcomes if EVAR can be successfully performed in that emergency setting.
What's required to rapidly and effectively treat a ruptured AAA? Time is obviously absolutely critical.
It truly is. Rapid and effective treatment requires highly trained personnel, immediate access to a full endovascular inventory, the devices themselves, and strict standardized protocols. Examples of protocols include systems for rapid transport directly to an operating room that is equipped with both open surgical and endovascular capability, minimal preoperative testing and imaging, because time is of the essence, and the crucial placement of an aortic occlusion balloon. That balloon should ideally be placed prior to the induction of anesthesia, as it can help support the patient's blood pressure regardless of which type of repair is ultimately offered. And regarding anesthesia, for patients amenable to EVAR for ruptured AAA, outcomes may actually be improved if general anesthesia is avoided altogether, and the procedure is performed under local anesthesia, further reducing physiological stress on a critically ill patient.
Many patients presenting with RAAA are already very sick with other problems. Are there scoring systems to help predict non-survivability and maybe guide decisions towards comfort care?
Yes. Many patients with ruptured AAA present with significant comorbidities or severe, acutely deteriorating clinical condition. For this reason, over the past 2 to 3 decades, many scoring systems have been proposed to predict non-survivability and therefore help guide those incredibly difficult decisions toward comfort care instead of attempts at definitive repair. However, these scoring systems either were developed before the widespread advent of EVAR or have not been adequately validated with contemporary care practices. The University of Washington scoring system is one of the few that predicts futility rather than just increased mortality risk, and therefore may be more useful in theory. But concerns about clinical usefulness exist. A recent institutional study demonstrated that only a very small proportion of patients actually met futility criteria with this scoring system, and overall outcomes in their cohort outperformed all the predictive models. This raises concerns about the true clinical usefulness of relying too heavily on such rigid scoring systems. As such, the consensus is that each patient should ultimately be judged individually to determine their suitability for intervention and definitive repair. It's about personalized care, even in emergencies.
So, highly individualized care is critical. What about interfacility transfers for these critically ill patients? Many hospitals might not be equipped.
That's a major issue. With increasing specialization of vascular surgery and the expansion of EVAR capabilities for ruptured AAA, many hospitals are indeed no longer equipped to provide the necessary comprehensive care. This necessitates the transfer of these critically ill patients. Utilization of transfer appears to be increasing, creating additional challenges for timely intervention. There's a paradox in the outcomes data. When available, local care may actually represent the best treatment initially. While operative mortality is often better for transferred patients, the overall mortality is actually worse. This paradox is most likely explained by selection bias. Only those patients who are clinically stable enough to receive treatment once they arrive at the receiving hospital are actually transferred in the first place. Those too unstable might not survive the transfer or be deemed candidates upon arrival. In fact, approximately 1 in 7 patients who are transferred do not ultimately receive treatment. This may be due to further clinical deterioration during transport, severe comorbidities that perhaps weren't recognized at the sending hospital, or sometimes patient refusal. To address these critical issues, current guidelines and regional societies provide specific recommendations for transferring patients with ruptured AAA, aimed at optimizing the transfer process and providing the greatest opportunity for definitive repair in those transferred patients.
Okay, let's delve into the fascinating, often terrifying world of acute aortic syndromes. You mentioned earlier we consider aortic dissection, AD, intramural haematoma, IMH, and penetrating aortic ulcers, PAU. together because of their significant interplay.
Exactly. They can really be thought of as different manifestations within a spectrum of aortic pathology involving the aortic wall itself, and they can even occur concurrently in the same patient.
So they're closely related, maybe different forms of the same underlying problem. What primarily separates them conceptually?
What primarily separates these three, in part, is the level of involvement of the aortic wall. So, while aneurysmal disease typically involves all three layers, the intima, media, and adventitia PAU is a disease primarily of the intima and media. AD and IMH are primarily diseases of the media, the middle layer. This understanding highlights that significant overlap between the three conditions.
Let's dive into aortic dissection AD first, often described as the aorta's most urgent emergency. What's its incidence and why is diagnosis still challenging?
Acute AD is indeed the most common clinical emergency involving the aorta, but its true incidence remains only an estimate. This is due to several factors, including the ongoing difficulties in making the diagnosis ante-mortem before death. Various prospective population studies and retrospective registries provide incidence estimates ranging from about 3.5 up to maybe 16.3 cases per 100,000 patient years. There are demographic differences too. Men are more frequently diagnosed with AD compared to women, around 16 per 100,000 compared to maybe 7.9 per 100,000 for women. Women also tend to present later in the course of the disease, are older at presentation, and unfortunately have worse in-hospital and surgical mortalities.
And what about the distribution between type A versus type B dissections and the typical age distribution?
Generally, thoracic type A aortic dissections, TADADs, occur more commonly than type B ADs, roughly by a 2-to-1 ratio for the population as a whole. However, type B AD is actually more common than TAD amongst Black patients, about 52.4%, PACEs 47.6%, highlighting some racial differences in disease patterns. Compared to aneurysmal disease, dissections occur across all age groups, showing a sort of bimodal pattern. Older patients typically have associated risk factors like hypertension and atherosclerosis, while younger patients often have underlying connective tissue and genetic disorders, as well as conditions like bicuspid aortic valve disease.
What are the main predisposing risk factors and syndromes that can lead to an aortic dissection?
Common factors include hypertension, that's a major one, connective tissue disorders, vascular inflammation, and disruption of the intima and media, perhaps from pre-existing conditions like PAU and IMH. These can all play a role in the mechanisms leading to the initiation of an AD. Certain genetic syndromes are strongly associated with AD, those with well-known genetic markers and mutations such as Marfan syndrome, mutation of the FBN1 gene, and Loeys-Dietz syndrome, mutations of TGFA1, TGFA2, TGFA genes. Less commonly affected genes include MYH11, ACTA2, and SMAD3. Some of these very same mechanisms may also be responsible for the development of aneurysmal dissection and intramural hematomas.
Are there other, perhaps less obvious risk factors like maybe illicit drug use?
Yes. When illicit drug use, particularly cocaine and methamphetamines, is present or suspected, patients tend to be younger and disproportionately present with type B dissections. It's suggested that it may not actually be the acute use of cocaine itself, but rather the long-term atherogenic effects of cocaine that predispose individuals to AD over time. There are also potential environmental and social factors that may transcend genetic factors alone. For instance, the Registry of Aortic Dissection in China, SINO-RAD, when compared to the International Registry of Acute Aortic Dissection, IRAD, describes acute TADs in the Chinese population as occurring at an earlier age, age 50.5 versus 61.1 years, with less associated hypertension, 51.4% to 67%, and a greater predominance of men, 76.3% to 66.9%. That's a really fascinating comparison showing potential regional or population differences.
It's clear that AD is incredibly serious, but it also seems like a real diagnostic conundrum because it can mimic so many other acute medical problems.
Absolutely. As noted by Aleftiades and colleagues, a dissection can mimic a whole variety of other acute medical problems, making diagnoses incredibly challenging for clinicians in the ER. These mimics include an acute coronary syndrome, a heart attack, stroke, paraplegia, lower extremity ischemia, lack of blood flow to the legs, acute renal failure, and even an acute abdominal catastrophe. Each of these problems arises from malperfusion, that inadequate blood supply to vital organs caused by the dissection flap. In a review of 526 patients ultimately diagnosed with acute TAD, 90% reported pain as a presenting symptom, while slightly over 20% had pain localized specifically in the abdomen. And the so-called pathognomonic or unmistakable sign of absent or differential pulses between arms or legs. That was present in only 139 of those 526 patients, meaning it's actually often not present. Only 31% of patients had normal abnormal ECGs, with more than 25% having ECG findings suggestive of myocardial ischemia, infarction, new Q waves, or ST segment deviations. Such ECG findings can easily lead to the misdiagnosis of an acute coronary syndrome, delaying crucial time to the correct diagnosis and treatment. Putting the difficulty in diagnosis into perspective. While the incidence of AD is maybe up to 16 per 100,000, this pales in comparison to acute coronary syndromes, around 440 per 100,000, and pulmonary embolism, about 69 per 100,000, both conditions which can present with very similar symptoms to AD.
That's a critical point. Misdiagnosis could clearly have fatal consequences. So what about the diagnostic imaging specifically for AD? How has our ability to confirm the diagnosis evolved over time?
Well, prior to the widespread introduction and implementation of CT scans, the diagnosis of an AD was actually made at autopsy in more than 25% of patients with the disease. That just underscores the severity and the historical diagnostic challenges. Thankfully, both CT and MRI are now highly useful in the diagnostic confirmation of a dissection, with reported sensitivities and specificities as high as 100%. They are really the gold standards now. CT imaging has the added benefit of providing that triple rule-out capability. This means using specific protocols regarding the timing of contrast administration to simultaneously rule out or rule in dissection, pulmonary embolism, or coronary artery calcification, a real game changer for rapid assessment in the emergency setting.
What about the role of echocardiography for diagnosing AD?
Transthoracic echocardiography, TTE, the standard bedside echo, is actually of limited utility for TAD, and really no utility for type B dissections. For TAD, TTE has a sensitivity range of only 35% to 80% and a specificity range of 35% to 96%, depending on the location of the TAD. Crucially, a normal TTE cannot reliably exclude the possibility of dissection. Transesophageal echocardiogram, TE, the probe down the esophagus, is more specific, 65%, 96%, and sensitive, 98% in diagnosing TAD, and can also detect a dissection flap in the descending thoracic aorta. A study by Shiga and colleagues demonstrated that pooled sensitivities, around 98%, 100%, and specificities, around 95%, 98%, were comparable between T, contrast-enhanced CT, and MRI, affirming their high diagnostic value when performed correctly.
Okay, so once an acute type A aortic dissection TED is definitively diagnosed, it's considered surgical emergency, isn't it? What's the management?
Almost always, yes. TADs are surgical emergencies, almost always requiring open surgical repair with only very rare exceptions. Medical management with impulse control therapy that's controlling blood pressure and heart rate can be used either as a temporizing measure to stabilize the patient before surgery or potentially for palliation in patients who are not deemed surgical candidates for various reasons. While there are some reports of endovascular repairs of TAD, this is generally not considered the standard of care for type A dissections. However, hybrid approaches are becoming more common. A prime example is the frozen elephant trunk technique. This addresses the proximal descending aorta with a covered stent at the same time as the open surgical therapy of the ascending aorta and arch, effectively combining the best of both worlds in one operation.
What's the mortality risk associated with AD? I've heard it quoted as being extremely high per hour without intervention.
That's correct. A frequently quoted risk of mortality for AD is 1% to 2% per hour in the first 24 hours for an untreated TAD. It's incredibly lethal. However, medical management with blood pressure and anti-impulse therapy can significantly reduce this initial 24-hour mortality rate while awaiting surgery. Subsequently, with surgical intervention, the hospital and operative mortality become more a function of the patient's characteristics and comorbidities rather than simply the time elapsed until diagnosis and treatment. Large clinical databases like the International Registry of Acute Aortic Dissection, IRAB, provide invaluable data for developing risk models through statistical analyses. For example, Mehta and colleagues identified age older than 70 years, abrupt onset of chest pain, shock or tamponade, bleeding around the heart, kidney failure, a pulse deficit, and an abnormal ECG as significant factors predicting postoperative mortality. A subsequent refinement of risk models divided factors into preoperative ones as well as intraoperative findings. The need for coronary artery bypass grafting, CAG, during the repair and the observation of right ventricular dysfunction generally bode poorly for outcomes. Interestingly, performing a right hemiarch replacement was identified as a favorable factor in that analysis.
And focusing specifically on malperfusion, that inadequate blood supply to organs caused by the dissection.
Yes, more recently, an important observation emerged. Patients without evidence of malperfusion had a significantly lower mortality rate than those who presented with malperfusion. This led to the development of a specific risk score that considers three key variables: creatinine level, indicating kidney function; lactic acid level, indicating tissue oxygenation; and evidence of liver malperfusion. The wide gamut of symptoms described by alephterides is primarily due to these different degrees and distributions of malperfusion. This raises a really important clinical question. Should malperfusion be addressed prior to the central surgical repair of the dissection itself? This approach appears to offer some benefit for operative mortality, but may potentially increase the risk for early and late mortality, posing a complex clinical challenge. The ongoing difficulty is developing a clear algorithm to identify precisely which patients will truly benefit from revascularization, restoring blood flow to ischemic organs before undergoing the central aortic repair. Overall operative mortality rates for acute TD are typically reported in the range of 15% to 25%, but they can be in the single digits in highly specialized multidisciplinary aortic surgery programs, which really highlights the significant impact of expertise and team integration.
Now, moving on to type B aortic dissections, those confined to the descending aorta, what's the initial management approach here? Is it different from type A?
Yes, it's generally different initially. Medical management of type B dissections is generally favored first, unless there is clear evidence of rupture or malperfusion. In those cases, it is classified as a complicated type B AD, and intervention is usually needed promptly. For uncomplicated type B, selective beta blockade remains the preferred first-line treatment. It offers that dual ability to lower blood pressure and also reduce aortic tension from the pressure impulse, the DPDT, or rate of change of pressure. The ultimate goal is a reduction of pulse pressure while maintaining adequate end-organ perfusion. It's important to appreciate that some antihypertensive medications might inadvertently increase pulse pressure while reducing mean arterial pressure because they preferentially lower diastolic pressure more. This conservative approach, particularly dominant in the pre-endovascular era, stemmed from the finding that in the acute phase for stable, uncomplicated type B dissections, the risk of intervention, open surgery back then, often exceeded the risk of watchful waiting with medical management.
But TEVAR, endovascular repair, has significantly changed the game for type B dissections as well, hasn't it?
Significantly, yes. With the major development of endovascular techniques, TEVAR has emerged as the treatment of choice for complicated type B dissections, i.e., those with rupture or malperfusion. It is also increasingly becoming an option for non-complicated dissections, although medical management currently remains the recommended standard of care for these non-complicated cases according to most guidelines. The primary goals of endovascular therapy for dissection include coverage of the primary intimal tear, the entry point of the dissection, and the obliteration and/or thrombosis, clotting, of the false lumen, that new channel created by the dissection, ideally promoting aortic remodeling.
How do mortality rates compare between open surgery, TEVAR, and medical management, specifically for type B AD?
Vittori and colleagues showed that in-hospital mortality for open surgical repair of acute type B AD was almost 34% in their series. That's a stark contrast compared to TEVAR and medical management, which were both in the range of 10%. It's important that the majority of patients, 68.3% in that particular study, were medically managed, with open surgical repair and TEVAR reserved mainly for complicated dissections. The higher mortality rate seen for open surgically managed patients in Vittori and colleagues' study was substantially higher than reported in other studies. A subsequent meta-analysis, for instance, found the pooled mortality rate for open repair was closer to 17.5%. This disparity in results likely reflects the ongoing paucity of large randomized studies that directly compare TEVAR with open surgery or medical management, as well as the lack of clear, consistent distinctions often made between complicated versus uncomplicated designations and the acuity of the presentation in reported series.
Let's touch on some of the key clinical trials that have looked at treating uncomplicated type B AD. The INSTEAD trial was the first big prospective one, right?
Yes, the investigation of stent grafts in aortic dissection INSTEAD trial was the first prospective trial to investigate TEVAR specifically for uncomplicated acute type B AD. At the 2-year mark, there was no difference found in all-cause deaths or aortic-related deaths between TEVAR and medical management groups. However, aortic remodeling, meaning the healing of the aorta, was favorable in the TEVAR group compared to the medical management cohort. These initial results were somewhat attributed to the study being potentially underpowered to detect survival differences. Then there was the ADS-ORBI trial, acute dissection, stent graft, or best medical therapy. This was a smaller trial prospectively comparing best medical therapy at BMT alone, N31, with BMT plus TVAR, N30, in patients with uncomplicated type B acute AD. The primary endpoint was a composite of factors including completeness of false lumen thrombosis, continued aortic growth, or aortic rupture at 1 year. At 1 year, the results favored the BMT plus TVAR group, chiefly due to the significantly higher rate of complete false lumen thrombosis in that group, 57% buddies, only 3%, a huge difference. However, the direct clinical significance of these specific findings from ADIS-OR, which was not powered to detect differences in aortic-related or all-cause mortality, remains somewhat unclear regarding long-term survival benefits. But an extension of the original INSTEAD trial, called INSTEAD XL, did find a benefit in aortic-related mortality in the TVAR cohort, specifically at the 5-year follow-up point, suggesting potential long-term advantages might emerge over time with TVAR.
What's the petticoat technique? It sounds like an interesting adjunct for managing the distal false lumen after TVAR.
Right. The petticoat technique, that stands for provisional extension to induce complete attachment, was initially described as an important adjunct to TVAR, particularly for complicated acute type B dissection. The original report noted that in 12 out of 100 patients treated with TVAR, there was persistent flow remaining in the distal false lumen, causing true lumen collapse and potential malperfusion. With the subsequent deployment of an uncovered stent distal to the previously implanted covered stent graft, there was successful reperfusion of the true lumen and abolishment of the malperfusion. These positive results persisted at 1 year, and there was also evidence of improved aortic remodeling. This technique has since been modified further to address the distal aorta in open repair of acute TIAD, DeBakey type 1, as part of a frozen elephant trunk technique. An even more extensive version, the extended technique, at petticoat, has even been proposed to preemptively address the entire descending thoracic and abdominal aorta with uncovered stents, with the anticipated benefits being complete aortic remodeling and the prevention of late aneurysmal progression. It's a testament to ongoing surgical innovation in this area.
Okay, let's move on to intramural haematoma, IMH. What exactly is this phenomenon within the aortic wall?
IMH is essentially a bleed contained within the aortic wall. It's a subadventitial lesion, meaning it's located beneath the outermost layer of the aorta, usually involving the outer third of the media, the middle layer. Its nomenclature follows the Stanford dissection classification. IMH involving the ascending aorta is type A IMH, and that confined to the descending aorta is type B IMH. One common hypothesis for how IMH develops is the rupture of a vasoviscorum. Those are the tiny blood vessels that supply the aortic wall itself, with subsequent intramural bleeding and hematoma formation within the wall layers. However, others have suggested that IMH may actually reflect an unrecognized aortic dissection that is subsequently seen on pathological examination, or perhaps demonstrated using very high-resolution contrast-enhanced CT scans. This raises a fascinating question. Is IMH a precursor to dissection, or is it really a subtle form of dissection itself? The debate continues among experts.
What's the incidence of IMH, and who is typically affected by it? Is it similar to AD?
IMH accounts for approximately 10% of acute aortic syndromes in Western countries, and may actually be even higher in Asian countries. The incidence might be underestimated, either due to misclassification of IMH as a discrete dissection, or perhaps the evolution of an IMH into a full AB during transfer to a tertiary center for treatment. Demographically, in contrast to AD, there seems to be a slight predominance of IMH seen in women compared to men. Type B IMH occurs more frequently than type A IMH. Patients presenting with IMH tend to be older and are more likely to be hypertensive than typical AD patients. Notably, Marfan syndrome or other connective tissue disorders do not appear to play a significant role in the development of IMH, which is a key differentiator from classic aortic dissection.
How does the clinical presentation of IMH compare to AD or maybe PAU?
Similar to AD and PIU, patients with IMH often present with acute chest or back pain. However, a potentially differentiating factor is that, in contrast to AD, the pain in IMH often does not radiate down the back or into the abdomen. This can be a subtle but important clinical clue. The overall clinical presentation of IMH may be suggestive in differentiating it from AD even before diagnostic imaging confirms the diagnosis. For instance, in type A IMH, complications like aortic valve insufficiency, distal malperfusion, and significant ECG abnormalities are generally not as frequent as they are in classic type A AD. However, the presence of a pericardial effusion, that's fluid around the heart, is actually increased in incidence in type A IMH compared to type A AD.
What are the key diagnostic imaging criteria specifically for IMH? How do you confirm it?
The sine qua non, or the essential feature, for diagnostic non-invasive imaging of IMH requires the presence of a thickened aortic wall, either localized or circumferential, that's greater than 5 millimeters thick, with no detectable blood flow within that thickened wall on CT imaging. The combination of CT imaging performed both with and without contrast has reported sensitivities greater than 95% for detecting IMH. TE has also been shown to have both a high sensitivity, 100%, and specificity, 91%, for diagnosing IMH.
So once IMH is diagnosed, how is it managed? Is it similar to AD?
Yes, the management of IMH is broadly similar to that of AD, with medical management generally limited to type B IMH. Anti-impulse therapy with a selective beta blocker is the therapy of choice for uncomplicated type B. As in the case of AD, signs that medical management might be failing include persistent pain despite medication, uncontrollable hypertension, progressively enlarging wall thickness, specifically more than 11 millimeters, and recurrent pleural effusions, fluid around the lungs. In these cases, intervention is needed. Interestingly, in contrast to type B AD, Falconi and colleagues demonstrated that medical and surgical management of type B IMH had similar mortality rates, 19% or 17% respectively. Because of this apparent equipoise or balance, type B IMH is perhaps more likely to be managed medically initially compared to type B AD.
What about type A IMH involving the ascending aorta?
Emergent or urgent management of type A IMH is typically recommended, especially if there's a pericardial effusion and ongoing pain, as rupture risk is high. Although in a highly selected group of patients, initial medical management and optimization has been reported, surgical intervention is often the necessary course. Open surgical repair of type A IMH proceeds similarly to that of TOD, but with two important caveats to keep in mind. First, finding truly normal aorta distally to SO2 may not be readily identifiable, so surgical judgment regarding the extent of resection is absolutely crucial. Second, clamping the aorta during the repair may inadvertently convert the IMH into a full dissection upon release of the cross clamp, presumably due to the creation of small intimal tears where the clamp is placed on the fragile wall.
And what about endovascular repairs for type B IMH? Are they an option like in type B AD?
Yes, similar to type B AD, endovascular repairs, TVAR, have emerged as a potential treatment option for selected cases of type B IMH. For an uncomplicated type B IMH, the European consensus guidelines recommend initial medical management and surveillance with non-invasive imaging. That's a Class I recommendation, meaning strongly recommended. However, with expansion of the hematoma, development of a periaortic hematoma, bleeding outside the wall, recurrent pain, or conversion to a frank dissection, the recommendations switch towards favoring intervention. TVAR, Class IA, meaning it's reasonable, or open repair, Class IB, meaning it may be considered. Evidence for TVAR is still evolving. Lai and colleagues compared TVAR with optimal medical management in their small series and showed no progression of IMH or mortality with the endovascular approach. Bischoff and colleagues also compared TVAR with medical management, and supporting the equipoise seen by Falconi, showed no difference in early or late mortality, incidence of complete remodeling, or regression between the two groups. Their results suggested that TVAR might perhaps be reserved for specific complicated cases of type B IMH. The main challenge with TVAR in type B IMH is determining the appropriate extent of coverage, similar to determining the extent of open repair. Since there is, by definition, no primary intimal tear to cover, the coverage territory becomes either presumptive of where the process might have started or targeted specifically in the case of an associated periaortic hematoma or an underlying PAU.
Okay, finally, in this spectrum of acute aortic syndromes, we have penetrating aortic ulcer, PAU. What is the nature of this condition?
As we noted, PAU involves both the intima and the media. It arises from an ulceration of an atherosclerotic plaque that has essentially burrowed through the elastic lamina, a crucial layer in the arterial wall. PAU can be associated with an adjacent IMH. It can serve as a nidus or source for initiating an AD, or it can lead directly to the development of a saccular pseudoaneurysm. Cody and colleagues found that in about 7.6% of their patients treated for either type A or BAD, there was an associated PAU identified. Isolated PAU itself accounts for maybe 2% to 7% of all acute aortic syndromes, AAS. Demographically, while there is an overall slight predominance in men, PAU occurs more frequently in the thoracic aorta in women and more frequently in the abdominal aorta in men. When considering only the thoracic aorta for both men and women, the descending aorta is the predominant site of occurrence about 90% of the time.
So it's often found in the descending thoracic aorta. What's the typical clinical presentation for PAU? Is it painful like dissection or a hematoma?
Actually, in contrast to AD and IMH, pain may not be a component of PAU at all. In a study from the Mayo Center, a significant 87% of patients with PAU were completely asymptomatic at the time of diagnosis. Often, the ulcer is detected incidentally during imaging performed for entirely other reasons, much like an asymptomatic aneurysm. Diagnostically, PAU is defined by a distinct focal outpouching, seen through an area of intimal calcification, or in an area with associated diffuse atherosclerosis when contrast-enhanced CT scanning is performed.
What about the management strategies for PAU? How are these handled?
Asymptomatic PAU may potentially be managed medically with anti-impulse therapy, blood pressure and heart rate control, and routine surveillance using non-invasive imaging. However, early intervention has been suggested by some for large PAUs, specifically when the greatest diameter is larger than 20 millimeters or the neck of the ulcer is larger than 10 millimeters. This more aggressive approach, however, has not been validated longitudinally. With open surgical repair, the involved segment is resected and replaced with a prosthetic graft or perhaps a homograft donor tissue. However, a significant challenge arises because PAU is associated with and really defined by the presence of severe atherosclerosis and calcification. This can make finding normal, healthy aorta proximally and dendrodistally to sew the graft very difficult for the surgeon. And regarding endovascular repair, TVAR for TO, while specific studies on its efficacy just for PAU are lacking, limited data have shown good results for TVAR in the setting of PAU when it leads to complications like pseudoaneurysm formation or rupture. However, the same challenges faced in open repair of PAU, namely that extensive atherosclerosis, may also pose problems for TVAR if the atherosclerotic disease extends significantly into the peripheral access vessels needed for the procedure, or if the presence of laminated thrombus often associated with PAU makes achieving a safe landing zone for the endograft difficult.
Okay, let's transition now to blunt thoracic aortic injury, BTAI, which is often the result of severe trauma, like car accidents. What's its incidence, and what are the typical mechanisms of this devastating injury?
The overall incidence of BTAI as a specific component of trauma admissions is relatively low, estimated at about 0.3% based on a large analysis of the National Trauma Data Bank over a 5-year period. However, of the over 3,000 patients with BTAI identified in that study, a significant 4% were already dead on arrival at the hospital, and another 19% died during triage in the emergency department. This really highlights the extreme lethality of this particular injury. Excluding those who died very early, 31% also had a major associated head injury and 29% had a major abdominal injury, indicating that BTAI often occurs as part of severe polytrauma, multiple serious injuries. Motor vehicle crashes remain the most common mechanism of aortic injury, accounting for over 70% of cases. It's estimated that BTAI may have been involved in a striking 33% of all motor vehicle deaths back in 2010.
Where in the aorta does this injury most commonly occur? Is there a specific weak spot?
Although the entire aorta is theoretically susceptible to BTAI, the most common site of injury by far is at the aortic isthmus. That's the area just distal to the takeoff of the left subclavian artery. It accounts for approximately 54% to 66% of cases based on autopsy studies. The injury at this specific site is typically a transverse tear across the aorta.
And why there, at the isthmus? Are there specific mechanisms proposed for how BTAI occurs due to trauma forces?
Yes, there are several proposed mechanisms based on the variety of complex mechanical forces that can be applied to the aorta during severe trauma. One is the stretching hypothesis. This suggests stretching of the aortic wall secondary to an intrinsic weakness at the isthmus, combined with the fact that the distal descending aorta is relatively immobile compared to the more mobile arch and ascending aorta during rapid deceleration forces. Another hypothesis includes bending, torsion, and shearing stresses occurring over the spine during high-impact injuries. And a third, particularly intriguing hypothesis is the Archimedes lever hypothesis. This proposes a lever system where the long arm is the proximal aorta and aortic arch, the short arm is the aortic isthmus, and the great vessels branching off the arch serve as a fulcrum. Simulations of lateral impact motor vehicle crashes have shown that the magnified forces mediated by this long arm can provide sufficient strain on the short arm, the isthmus, to result in rupture. Realistically, it's likely that a combination of all of these complex mechanisms plays a role in the etiology of BTAI, reflecting the severe biomechanics involved in high-energy trauma.
How do clinicians classify the severity of BTAI? And what are the main diagnostic approaches used today?
BTAI classification is based on the extent of the damage to the aortic wall layers. There are 4 different grades, each associated with different management strategies. Grade 5 is an intimal tear. This is the least severe, where the injury does not cause any changes to the external contour of the aorta. It's best visualized with either CTA, CT angiography, or IVUS, intravascular ultrasound, as a standard angiogram might actually be interpreted as normal, potentially missing the subtle but important injury. Grade 2 is an intramural haematoma. This injury causes an abnormal aortic contour that can be visualized on CTA, IVUS, or conventional angiography. Grade 3 is a pseudoaneurysm. This more severe injury involving that outpouching can be visualized with any imaging modality. And grade 4 is rupture. This represents a complete breach of the aortic wall and can be visualized with any imaging modality, often presenting as frank active hemorrhage. Historically, at the time of the AAC multicenter trial of BAI, a ACI trial, aortography was the most common diagnostic modality, and the standard treatment for stable patients was open operative repair. However, modern diagnosis has advanced significantly. Multi-detector CTA is now considered the gold standard diagnostic modality for BTAI in the updated AAST guidelines.
What findings on a plain film chest X-ray might suggest BTAI, even if it's not the definitive diagnostic tool anymore?
While not definitive, the most common finding on a plain film chest radiograph that's suggestive of BTAI is a widened mediastinum. That space between the lungs appears abnormally wide. Other findings that might indicate BTAI include an apical pleural cap, a collection of fluid at the very top of the lung, loss of the aortopulmonary window, a specific space normally seen on chest X-ray, rightward deviation of the mediastinal structures or the endotracheal tube, if one is present, or depression of the left main stem bronchus. These are all indirect signs of potential aortic injury.
So how has the actual management of BTAI changed over time, and what are the outcomes like now?
Modern treatment of BTAI has changed dramatically. Current options now include aggressive blood pressure control as a primary step and increasing indications for endovascular repair, TVAR, as a preferred method of definitive repair when needed. The Society for Vascular Surgery, SVS guidelines, provide recommendations for management based on the grade. For grade 1 injuries, those minor intimal tears, the SVS recommends expectant management. This involves strict blood pressure control and serial imaging, typically a repeat CTA in about 6 weeks, as most of these minor injuries heal spontaneously without intervention. For grade 2, 3, and 4 injuries, repair is generally recommended due to the higher risk of progression or rupture. In a review by Arthurs and colleagues, 68% of patients with BTAI who survived to receive treatment were initially managed medically, blood pressure control. However, performing aortic repair, when indicated, independently improves survival after controlling for other associated injuries, suggesting a clear benefit for definitive intervention for significant injuries.
Can you elaborate a bit on the specifics of that medical management, particularly for grade 1 BTAI? What are the targets?
For medical management of grade RUS BTAI, Fabian and colleagues recommended maintaining a systolic blood pressure less than 100 mm Hg or a mean arterial pressure less than 80 mm Hg, along with heart rate control targeting less than 100 beats per minute. These parameters are typically achieved using intravenous beta blockade, such as esmolol or labetalol infusions. Nitroprusside might be added if satisfactory blood pressure control is not achieved with beta blockers alone. The goal is to reduce the stress on the injured aorta wall.
What about endovascular repair, TVAR, specifically for traumatic aortic injury? How has that evolved?
Since the very first report of endovascular repair of a traumatic injury to the thoracic aorta back in 1997 by Cato and colleagues, the data have substantially increased to support the use of endovascular stent grafts over a traditional open repair for BTAI. Early experience didn't show a significant difference in mortality rates between open and endovascular repair, around 19% and 18% respectively. However, subsequent improvements in techniques and device technology have led to consistently reduced rates of mortality, now reported around 8%, 9% for TVAR versus 19% for open, paraplegia, 0.5%, 3%, and 9%, and end-stage renal disease, 5%, 8%. Stroke rates are comparable between the two, around 2.5%, 1%. This represents a really clear shift towards TVAR as a preferred approach due to these significantly improved outcomes.
What about the timing of repair for these grade 2-4 injuries? When should it happen?
The Society of Vascular Surgery recommends that for those undergoing repair, the timing should ideally be within 24 hours, assuming there are no other serious life-threatening injuries that take precedence. Or it should be repaired immediately after those other critical injuries have been treated, or at the very latest, before the patient is discharged from the hospital. You don't want to send someone home with an unstable aortic injury. The SVS has specific recommendations for TVAR in BTAI. They advocate endovascular repair in anatomically suitable candidates, with selective revascularization of the left subclavian artery, SCA if needed, routine administration of heparin, though often at a lower dose than elective Duvar, the use of general anesthesia, and typically open femoral exposure for sheath access, although percutaneous access is sometimes possible.
Why is covering the left subclavian artery often necessary in BTAR repair, and what's the thinking around revascularizing it?
The presence of an adequate 2 centimeter proximal seal zone, which is crucial for graft stability and preventing leaks, often requires partial or complete coverage of the left SCA origin, simply because the aortic isthmus right near the SCA is the most common site of injury. The decision to perform revascularization of the left SCA, usually via a carotid subclavian bypass, is highly individualized, according to the SVS practice guidelines. It must carefully consider the status of the right vertebral artery anatomy and the posterior circulation, blood supply to the back of the brain, the availability of surgical expertise, the overall condition of the patient, and the presence of other injuries. As mentioned before, revascularization, if performed, is typically accomplished with that carotid subclavian bypass graft.
So TVAR is clearly the preferred method for most BTAR repairs now, but are there patients who are generally not candidates for it?
Yes. Patients with injuries involving the ascending aorta or the aortic arch itself should generally undergo open repair if feasible. They are usually not considered candidates for standard endovascular repair due to the complex anatomy and critical branch vessel involvement in these areas, which current TVAR devices are not designed to handle easily or safely.
Okay, let's go even deeper now into some specific surgical management considerations across different aortic conditions. We'll start with acute type A aortic dissection, T repair, which you've emphasized is truly high-stakes surgery.
Absolutely. Open surgical repair of an acute TAE remains the undisputed standard of care when the patient is deemed a suitable surgical candidate.
Have there been noticeable trends in how these are managed over time? Are more people getting surgery now?
Yes, definitely. As reported by the International Registry of Acute Aortic Dissection, IRA, in tertiary medical centers that have expertise in TAD treatment, between 1995 and 2013, the proportion of patients who are relegated solely to medical management declined significantly from about 21% down to 10%, and this corresponded with a very positive trend. A decline in the surgical mortality rate from 25% down to 18% over that same period. This really shows that with increasing experience and centralization of care in specialized centers, surgical outcomes have markedly improved.
Even with these improved outcomes from surgery, are there still situations considered relative contraindications to operating on an acute TED?
While surgery is the standard, certain factors are definitely considered relative contraindications. Advanced age, for example, is always a concern. Although one study by Stamo and colleagues did not see a difference in operative mortality or major morbidity in a comparison between patients older than 70 years and those younger, octogenarians patients in their 80s generally do not fare as well overall. Interestingly, IRAD data has actually shown no difference in outcomes for octogenarians, whether they were treated with surgical intervention versus medical intervention alone, suggesting that for some very elderly, perhaps frail patients, medical management might actually be a comparable option in terms of survival.
What other factors might weigh against surgery?
The presence of multiple significant comorbidities is a major factor. Neurologic status at presentation is also critical. Patients presenting with a cerebrovascular accident, stroke, or in a coma have that condition significantly impact their hospital survival chances. However, it's important to note that for those who do undergo surgical repair despite presenting with stroke, there is improved survival compared to medical management alone. Furthermore, in a reported 84.3% of patients presenting with cerebrovascular accident who underwent surgical repair, there was actually a resolution of the neurologic deficit after surgery, highlighting the potential for remarkable recovery even in dire circumstances. Then there are softer contraindications. These might include concern for the risk of bleeding secondary to pre-existing antithrombotic medication or a patient's refusal for blood transfusions, for example in the case of a Jehovah's Witness, which presents unique ethical and medical challenges for the surgical team.
Once the decision is made to proceed with surgery for TAD, what are the primary surgical goals? What are you trying to achieve?
The primary goals are very clear and focused. First, elimination of the entry tear, that's where the dissection actually begins. Second, obliteration of the false lumen in the aortic root and the ascending aorta. Successfully completing these two primary goals will often address the secondary issues that arise from the dissection, such as aortic valve insufficiency, a leaky valve, and distal visceral malperfusion, that inadequate blood flow to the abdominal organs. Every patient presents a unique set of challenges, of course, requiring tailored approaches, particularly when it comes to the cannulation strategy, how you establish arterial inflow for cardiopulmonary bypass, the heart-lung machine.
Cannulation is clearly critical for connecting the patient to the heart-lung machine. What are the key considerations and options there?
Traditionally, femoral artery cannulation in the groin was the primary access route, mainly due to the ability to rapidly establish access either via surgical cut down or percutaneously. A key clinical paradox here, though, is that the femoral artery most likely to actually be in continuity with the true lumen, the normal blood channel, is often the one without a palpable pulse, because the true lumen might be collapsed by the false lumen pressure. If the wrong vessel, the false lumen, is cannulated in such a situation, it can result in dangerously high pressures in the bypass circuit. Despite this theoretical risk, clinically significant malperfusion resulting directly from femoral cannulation is actually uncommon. Axillary artery access, usually under the collarbone, grew popular, partly due to its ability to be used as part of a selective cerebral perfusion technique during periods of circulatory arrest, which helps protect the brain. Additional benefits include the avoidance of atheroembolization, sending cholesterol plaque fragments into the circulation from manipulating atherosclerotic vessels, and avoiding false lumen perfusion, inadvertently pumping blood into the dissecting channel. Other approaches that have been described include arterial access via the apex of the left ventricle with the cannula actually traversing the aortic valve, direct cannulation of the true lumen after transection of the ascending aorta, sometimes dubbed the samurai technique, and echo-guided cannulation of the ascending aorta or arch using a Seldinger needle-over-wire technique.
Cerebral protection during these extensive repairs is paramount. How is hyperthermic circulatory arrest used to achieve this?
Right. With some specific exceptions, acute TED repair is typically performed with a period of hypothermic circulatory arrest, HCA. This involves cooling the patient's body significantly, often down to 18 to 20 degrees Celsius, and temporarily stopping all blood circulation to protect the brain while the surgeon works on the open aorta. Historically, the initial approach to the arch reported by DeBacchi back in 1957 actually included a multi-catheter approach to the great vessels and one of the femoral arteries to provide arterial inflow without circulatory arrest, but HCA became the standard. The benefits of hypothermic circulatory arrest are that it allows the establishment of a completely bloodless surgical field, which is crucial for evaluating the distal ascending aorta and the arch to confirm intimal integrity. It also ensures the graft is sewn only to the true lumen and assists in the obliteration of the false lumen proximally. Profound hypothermic circulatory arrest provides about 30 to 40 minutes of protective cerebral time. Deep hypothermia alone should generally be sufficient for performing open distal anastomoses and hemiarch repairs. To extend that safe operating time for more complex repairs, the use of either unilateral selective antegrade cerebral perfusion, SACP, pumping blood directly into one carotid artery, or bilateral antegrade cerebral circulatory perfusion extends this protective time considerably. With the adjunct of SACP, moderate hypothermia, cooling to maybe 25-28 degrees Celsius, has been shown to be safe and effective, potentially reducing some systemic effects of deep hypothermia. SACP, often delivered via right axillary artery cannulation, perfuses the brain via the right carotid artery and assumes the absence of significant right carotid stenosis and an intact circle of Willis, that circulatory anastomosis at the base of the brain allowing flow between sides. There's always concern for coagulopathy or bleeding disorders secondary to hypothermia, but adequate rewarming at the end of the procedure should generally be sufficient to address this concern.
Let's discuss the actual conduct of cardiopulmonary bypass during these complex surgeries. How does that proceed?
Okay. Once the patient is successfully cannulated and cardiopulmonary bypass is initiated, systemic cooling is started. The target temperature is based on surgeon preference, their experience, and specific patient characteristics. Topical ice placed on the patient's head is typically included as an adjunct, although clear evidence of its efficacy is somewhat limited. There is currently no broad consensus regarding the optimal rate of cooling or the preferred acid-base management strategy, alpha stat versus pH stat, during the cooling phase. The surgeon really needs to discuss the target temperature and strategy with the anesthesia and perfusion team as part of the detailed operative plan. Routine clamping of the ascending aorta during the cooling phase isn't necessarily required. Distension of the left ventricle, however, may occur because of the presence of aortic valve insufficiency caused by the dissection. If this distension becomes significant, the ventricle can be vented in a number of ways using catheters inserted via the right superior pulmonary vein, the pulmonary artery, or directly via the apex of the ventricle itself to drain blood. If venting is unsuccessful in reducing distension, the ascending aorta can be clamped and transected proximally. Concomitant myocardial protection must then be provided via either retrograde cardioplegia into the veins of the heart or direct antegrade cardioplegia into the coronary arteries. A suggestion has been made for routine clamping of the ascending aorta during the cooling phase, with the proximal portion of the repair completed during this phase to potentially lessen the total length of the cardiopulmonary bypass period. However, the overall length of the surgery is often more impacted by the time it takes for the rewarming phase rather than the cooling phase. Additionally, an alternative strategy is when the distal anastomosis, further from the heart, is completed first during circulatory arrest. That anastomosis can then be tested with direct vision of the entire suture line, and rewarming can then be initiated while the proximal aorta and root are dealt with, offering a different strategic sequence.
The extent of the reception and repair, both proximally towards the heart and distally away from it, also seems like a critical decision point with potential debate.
Absolutely. The extent of repair has been a subject of considerable debate, reflecting the complexity and variability of each unique dissection. The aortic root itself is not infrequently involved in acute TADA. Often, simple resuspension of the aortic valve commissures, those points where the valve leaflets meet, in addition to reapproximating the walls of the sinuses, the bulges above the valve, using techniques like glue or felt, is sufficient to provide integrity to the aorta and correct the aortic valve insufficiency. Barring that simple approach being successful, the root should be definitively addressed at the time of the initial repair if it's significantly damaged or dilated. As in the case of elective root replacement, which we'll discuss next, the goal in the acute setting should be to choose the procedure that can be most efficiently and successfully accomplished given the emergent life-threatening situation. Sometimes the simplest, quickest, effective repair is the best one.
Okay, that leads us nicely into aortic root replacement itself. This is primarily performed for aneurysmal disease or acute type A dissection, but you mentioned also for certain cases of aortic valve endocarditis, infection, and reoperative aortic valve replacement.
That's correct. Those are the main indications. Anatomically, remember, the boundaries of the aortic root are the aortic annulus proximally, where the valve attaches, and the sinotubular junction distally, where the sinuses meet the tubular ascending aorta. Components of the root include the aortic valve itself and the ostia, or openings, of the coronary arteries that supply the heart muscle. Thus, when the aortic root is repaired or replaced, with very few specific exceptions, the coronary arteries are always reimplanted onto the new graft or bypassed with separate grafts. The valve itself is addressed, either replaced or sometimes spared. And circulatory arrest is generally not needed unless the ascending aorta further up is also impacted and needs to be replaced concurrently.
And there are essentially three standard approaches to aortic root replacement that surgeons might consider.
Yes, broadly speaking. First, there are composite valve grafts, CVGs. The original Bentel procedure, described by Bentel and colleagues, has undergone significant modifications over the years, making the term itself somewhat anachronistic as the technique has evolved considerably. The original description involved a CVG with an inclusion technique to deal with the coronaries, basically sewing the native aortic wall containing the coronary ostia around the graft. Wheat actually preceded Bentel in an earlier publication describing a technique where the valve and graft were separate components, and the coronaries were reimplanted on tongues of aortic wall extending from the annulus. Subsequent work by Kachukos and colleagues incorporated the now familiar and widely used coronary button technique, where the coronary arteries are excised as small buttons of aortic wall and then reimplanted directly onto the new graft. The composite valve graft concept then evolved into pre-constructed manufactured composite units, initially available only with a mechanical valve, but later with biologic tissue valves offered as an option as well. With both mechanical and tissue options available, the indications for the type of CVG used are generally the same as for a standalone aortic valve replacement. Mechanical valves are typically favored in younger patients due to their exceptional durability, but require lifelong anticoagulation, while tissue valves are often preferred in older patients, or when lifelong anticoagulation with warfarin is not a reasonable or desirable option for the patient.
So if a patient wants to avoid lifelong anticoagulation, a tissue valve is often the choice. What about options for complete tissue replacement of the root, still avoiding anticoagulation?
Right. Balancing the desire for a durable valve or root replacement with the avoidance of lifelong anticoagulation led to a number of innovative techniques using biological tissue entirely. One is the Ross procedure. Based on earlier work by Lower and Shumway and promoted by Donald Ross, this resulted in the eponymous Ross procedure. It's an ingenious technique involving the autotransplantation of the patient's own pulmonary valve into the aortic position. The pulmonary artery root is then subsequently replaced with a cadaveric homograft, donor tissue. While the procedure never gained widespread popularity in adult patients due to its technical complexity and concerns about late failure of the autograft or homograft, it remains a viable alternative, especially when performed in high-volume environments by experienced surgeons. It offers the theoretical advantage of not needing anticoagulation and potentially increased durability compared to a standard tissue valve, especially in younger patients. An alternative to the Ross procedure is the direct replacement of the aortic root with a cadaveric homograft. This is notably indicated in the setting of destructive aortic valve endocarditis infection with destruction of the aorta annulus itself. Both the Ross and homograft procedures have the theoretical advantage of avoiding the need for anticoagulation and potentially offering increased durability compared to a standard tissue valve. However, both procedures are technically very challenging, and their long-term outcomes are highly dependent on the experience of the surgeon and the center.
And then there's the third option, valve-sparing root replacement, which aims to preserve the patient's own native aortic valve. When is this approach appropriate?
This is a great option when possible. Dilatation of the aortic root itself, or just of the senotubular junction due to an ascending aortic aneurysm, may result in valve insufficiency, a leaky valve, even when the native valve leaflets themselves are anatomically normal. In this specific setting, replacing a perfectly normal valve while addressing the aortic root or ascending aorta seems like, well, overkill, potentially subjecting the patient to unnecessary valve-related risks later. If only the sinotubular junction is dilated, sometimes simply replacing the ascending aorta with a slightly downsized graft may, while a detailed expansion on each valve-sparing technique is beyond the scope of this deep dive. Miller summarizes the primary difference between the Yaku remodeling and David reimplantation techniques, mainly by the number of aortic suture lines involved. Remodeling typically employs 2 aortic suture lines, while reimplantation uses 3, suspending the valve inside the graft. Both techniques use a synthetic Dacron graft as the neo-aorta, the new aorta, and both, as previously mentioned for other root replacements, require reimplantation of the coronary ostia, usually as buttons. There is an exception to the comment that the coronaries are always reimplanted as buttons. The Florida sleeve technique, where slots are actually made on the Dacron graft to accommodate the coronary origins without detaching them completely, representing another innovative modification.
Okay, let's talk about open surgery, specifically of the descending thoracic aorta. It sounds like its role has shifted quite dramatically with the rise of endovascular techniques.
Indeed, it has. Open surgical repair of thoracic aortic pathology has changed profoundly since the widespread introduction and adoption of endovascular techniques, specifically TEVAR. While TEVAR now plays a predominant role in the management of most descending thoracic aortic diseases, there definitely remain clinical scenarios in which a thorough knowledge of open approaches to the thoracic aorta is still an important part of the surgeon's armamentarium. As we mentioned previously, TEVAR may not always be appropriate or technically feasible for some complex type B aortic dissections. And with a few exceptions, it's generally not applicable to patients with Marfan disease or other connective tissue disorders where the inherent tissue quality is often not suitable for secure endograft fixation and sealing. Importantly, issues regarding spinal cord protection and intraoperative monitoring are pertinent to both open and endovascular techniques, emphasizing their shared complexity and risks in this region. Considerations specific to open surgery include the need for and the specific approach to distal perfusion during the clamp time, whether to use a clamp and sew technique, left heart bypass, or full cardiopulmonary bypass, as well as the surgical access approach itself, usually a thoracotomy. Many of these issues and considerations with open thoracic aortic surgery also pertain directly to thoracoabdominal aortic aneurysms, TAAAs, which we'll discuss in more detail next.
What about intraoperative monitoring during these complex open thoracic procedures? What's typically used?
Hemodynamic monitoring is critical. Invasive arterial lines are required during open repair of thoracic aneurysms and dissections. This may necessitate transducing or measuring pressure from both upper body arm and lower body leg sites, depending on the surgical plan, to ensure adequate perfusion is maintained throughout the body during clamping. Pulmonary artery catheterization is not typically that helpful during the intraoperative period itself, but can certainly be useful in postoperative management for assessing cardiac function and fluid status. The use of transesophageal echocardiography, TEE, is considered reasonable in open surgery as well as during TVAR, and carries a Class 3 recommendation in a 2010 consensus statement indicating its strong utility for assessing cardiac function and looking for complications. A second Class 3 monitoring recommendation relates specifically to spinal cord perfusion, acknowledging the devastating potential of spinal cord ischemia, lack of blood flow, leading to paralysis following surgery on the thoracic aorta. While not a therapeutic modality itself, monitoring motor-evoked potentials, MEPs, or somatosensory-evoked potentials, SSEs, measuring nerve signals can help guide therapy and allow for alterations in intraoperative management if signals deteriorate, allowing surgeons to potentially detect early signs of ischemia and react.
Spinal cord protection is clearly a paramount goal in these surgeries. Can you elaborate on the strategies used?
Absolutely. Avoidance of spinal cord injury secondary to ischemia is paramount in surgery of the thoracic and thoracoabdominal aorta, and this applies to both open and endovascular approaches. Key adjuncts used to protect the spinal cord include cerebrospinal fluid, CSF drainage, distal perfusion, providing blood flow below the clamp, either via left heart bypass or full cardiopulmonary bypass with femoral cannulation, therapeutic hypothermia, cooling the body, and various pharmacotherapeutics, drugs. The rationale for CSF drainage is to increase the spinal cord perfusion pressure, SCPP, by lowering the CSF pressure within the spinal canal. The formula for SCPP is SCPP equals mean distal aortic pressure minus CSF pressure plus central venous pressure. Thus, SCPP can be favorably increased by increasing distal aortic pressure, by providing blood flow distally, by decreasing CSF pressure through drainage, and potentially by decreasing central venous pressure. Management of the CSF drain itself varies between centers. Some set a limit of CSF pressure, for example, keeping it below 10 to 15 millimeter Hg, while others drain CSF at a constant rate, for example, 10-20 cc per hour. Whichever approach is used, two things must be remembered. First, in instances of acute changes in neurologic status detected by monitoring, an immediate drainage of 10 to 20 cc's of CSF may potentially salvage the spinal cord. Second, the two other variables related to SCPP, namely aortic pressure and central venous pressure, can also be manipulated pharmacologically or by fluid management to maximize SCPP. It is crucial to note, however, that CSF drainage is not an innocuous procedure. Almost 10% of patients develop a post-dural puncture headache, and there's a reported 2.8% risk of intracranial hemorrhage, the majority being subdural hematoma, so it carries risks.
How is maintenance of distal perfusion achieved during open thoracic surgery?
Maintenance of distal aortic pressure and perfusion of visceral branches, including important collateral arteries to the spinal cord, can be supplemented with various forms of circulatory support. For procedures on the thoracic aorta associated with dissection, cardiopulmonary bypass (CPB) may be preferable, since it provides not only circulatory support but also a mechanism for precise temperature regulation, allowing for hypothermia, and rapid volume infusion if needed. For both complex thoracic and thoracoabdominal procedures, the use of deep hypothermic circulatory arrest, DHCA, has been championed by some centers. It eliminates the need for proximal and sequential aortic clamping, and the associated difficult periaortic dissection required for placing clamps, provides easy proximal access up into the arch, creates a bloodless field for meticulous suture placement, and importantly allows for the return of all shed blood back to the perfusion circuit, minimizing blood loss and transfusion needs. Interestingly, for less extensive descending thoracic aortic aneurysms, Caselli and colleagues found no difference in paraplegia rates when comparing left heart bypass versus the simpler clamp and sew technique, 4% and 2.3% respectively, which was not statistically different. This suggests that for some more localized repairs, simpler techniques may be equally safe concerning spinal cord outcomes, potentially avoiding the complexities of bypass.
Now, let's turn specifically to thoracoabdominal aortic aneurysms, TAAA repair. This sounds like one of the most complex and challenging operations in vascular surgery.
It certainly is. For TAAA repair, an incision that enters both the thoracic and abdominal compartments is typically required, a thoracoabdominal incision. This represents a significant physiological stress on the patient. For this reason, the preoperative workup may need to be more extensive than for other aortic procedures, often including detailed pulmonary function tests and more intense evaluation of cardiac function, all aimed at optimizing the patient for this very demanding surgery. Regarding circulatory support during the repair, although it can be performed with a clamp and sew technique, where the aorta is clamped above and below the aneurysm and the repair is done rapidly and the resulting bloodless field. Most high-volume centers today perform TAA repair with either left heart bypass or full cardiopulmonary bypass, often combined with hypothermic arrest. This latter approach, using hypothermic arrest, is specifically advantageous for extent 2 TAAs, those involving the entire thoracic and abdominal aorta, where there might not be a safe location for clamping the most proximal aorta high in the chest. It allows for profound cooling and temporary circulatory arrest to facilitate the proximal anastomosis safely.
And paraplegia, that feared complication, remains a significant concern here as well.
Absolutely. As in descending thoracic aortic procedures, paraplegia remains an uncommon but greatly feared complication of TAA repair. Critically, mortality after TAA repair is significantly increased should paraplegia unfortunately develop, which underscores the paramount importance of preventative strategies. The risk of paraplegia is known to be increased with extent TAAs associated with aortic dissection, those presenting acutely ruptured or symptomatic, as opposed to electively, or in patients who have had previous infrarenal aortic surgery, which may have compromised important collateral blood supply pathways to the spinal cord. Protective measures focus on maximizing spinal cord perfusion. Increasing spinal cord perfusion pressure, CPP as previously discussed, by using CSF drainage and actively maintaining distal aortic pressure during clamping may be protective. Other approaches aimed at maximizing spinal cord perfusion include the meticulous reimplantation of critical intercostal arteries, those arteries branching off the aorta that supply the spinal cord, particularly the artery of Adenkiewicz, and maintaining adequate central perfusion pressure throughout the case. Strategies aimed at decreasing the metabolic rate of the spinal cord itself, making it less vulnerable to temporary ischemia during clamping, may include things like preoperative steroids, the intraoperative use of a naloxone drip, inducing moderate hypothermia, cooling the patient systemically to around 34 degrees C, and potentially the injection of neuroprotective agents like propofol just prior to aortic clamping. The effectiveness of some of these pharmacologic adjuncts is still debated, however.
How is the graft construction handled? Specifically regarding the visceral vessels, the arteries supplying the abdominal organs like kidneys, intestines, liver.
The construction of the visceral component of the graft, how those crucial arteries supplying the abdominal organs are reattached to the new aortic graft, may depend significantly on the underlying cause for the TAAA repair. For patients with degenerative TAAA, the most common type due to atherosclerosis, using a Carroll patch, which is a segment of the patient's original aortic wall containing the origins of the visceral arteries, all sewn together as one patch onto the graft may be considered for the reimplantation of the visceral vessels. This approach can potentially simplify the operation and decrease the visceral ischemia time, the time the organs are without blood flow, but it may carry a long-term risk of future degeneration of that residual native aortic patch and subsequent pseudoaneurysm formation at the reattachment site years later. Therefore, for patients with connective tissue disorders, like Marfan or Ehlers-Danlos, or those with aneurysmal degeneration of a previous dissection where the native aortic tissue is inherently weak or diseased, most surgeons would favor using individual branch grafts sewn separately to each visceral artery. This approach thereby eliminates any suspect native aortic tissue from the repair altogether, theoretically offering a more durable long-term solution in these fragile aortas, although it is technically more complex and time-consuming.
Let's move down the aorta now to open infrarenal abdominal aortic aneurysm, AAA repair. This is really a foundational operation in aortic surgery. What are the main approaches?
Yes, open repair of an infrarenal AAA is a classic vascular surgery procedure. It can be performed through either a transabdominal approach, going straight through the abdomen via a midline incision, or a retroperitoneal approach, coming in from the patient's side, staying behind the abdominal cavity lining. The transabdominal approach is probably more common overall. Its advantages include the ability to inspect the entire abdominal contents for any other pathology. It allows for supraceliac control, getting clamp control of the aorta above the celiac artery if needed, without necessarily needing to enter the chest cavity. And it generally provides better exposure of the right iliac bifurcation and the external iliac arteries if the repair needs to extend down that far. Potential disadvantages of the transabdominal approach may include a higher risk of incisional hernia formation later on, an increased risk of postoperative bowel obstruction due to adhesions, and perhaps a slightly increased risk of the rare but very serious late complication of aortoenteric fistula, an abnormal connection forming between the aortic graft and the bowel.
Can you give us a brief overview of the steps involved in the transabdominal approach?
Sure. After the abdominal contents are inspected, the omentum and transverse colon are retracted upwards towards the head, and the small intestines are carefully retracted over to the patient's right side. This exposes the retroperitoneum and the ligament of Treitz, a peritoneal fold near the duodenum. The ligament is taken down, and the duodenum, the first part of the small intestine, is mobilized and retracted to the right. It's good practice to leave a small slip of tissue attached to the duodenum for later closure of this retroperitoneal space after the repair, which helps prevent internal bowel herniation. A self-retaining retractor system is very helpful to maintain optimal exposure throughout the procedure. The posterior parietal peritoneum, the lining behind the abdominal organs, is then incised longitudinally over the aorta to expose it. The dissection is carried proximally upwards to expose the aneurysm neck, that segment of relatively healthy aorta, just above the aneurysm where the proximal clamp will go. The inferior mesenteric vein is generally encountered during this dissection and should be identified, carefully retracted, or sometimes ligated and divided if necessary for exposure. As the dissection is carried further cephalad towards the renal arteries, the left renal vein is encountered crossing over the aorta. This vein can sometimes be duplicated or travel behind the aorta, retroaortic. Its specific course can and should be identified on preoperative imaging to avoid inadvertent injury during dissection. The left renal vein can usually be retracted, and if needed, its adrenal and gonadal vein tributaries can be divided to provide more mobility. Some surgeons have advocated for division of the left renal vein itself in certain difficult exposures. If this is considered, the adrenal and gonadal veins must be left intact, as they will subsequently provide the primary venous drainage pathway for the left kidney. Proximal aortic control should be obtained at a healthy segment of aorta, free of significant plaque or thrombus, and with enough room below the renal arteries to safely place sutures for the anastomosis. Control can be obtained either circumferentially, dissecting all the way around the aorta, allowing an occlusion clamp to be placed transversely, or by dissecting just anteriorly and on either side of the aorta down to the spine, allowing for an angled clamp placement. The dissection is then carried distally, downwards. If a straight tube graft, just replacing the aortic segment, is planned, it's generally safer to control the bilateral proximal common iliac arteries just below the bifurcation to avoid potential injury to the iliac veins, which travel directly behind the arteries and may be more densely adherent at the aortic bifurcation itself. If dissection and arterial control are required further down, at or past the iliac bifurcation, great care must be taken to identify and avoid injuring the ureters as they traverse anteriorly over the vessels at this level.
Okay, so once the dissection is complete and control is obtained, what happens next? Clamping and graft placement.
Exactly. Once the dissection is complete and the surgeon is ready, the patient should be given intravenous heparin, typically at a dose of around 100 units per kilogram, prior to applying the aortic clamps. The goal is to achieve an activated clotting time, ACT, of 250 to 300 seconds, which is then maintained for the remainder of the case to prevent blood clots from forming while the aorta is clamped. Once clamped, the aneurysm sac itself is opened longitudinally. Any thrombus clot within the aneurysm sac is carefully removed. Back bleeding from lumbar artery branches coming off the back wall of the aneurysm should be controlled with suture ligatures, basically tying them off from inside the sac. The origin of the inferior mesenteric artery, IMA, which usually comes off the front left side of the aneurysm, should be inspected from within the sac. If back bleeding from the IMA is absent or very brisk, indicating good collateral flow, it can also be suture ligated from the inside. However, if the back bleeding is scant or weak, the IMA should probably be preserved for possible reimplantation later, as it may represent a crucial collateral blood supply to the left colon, and ligating it could lead to colon ischemia. An appropriately sized prosthetic graft, usually made of polyester Dacron or polytetrafluoroethylene, PTFE, is then selected and sewn into place, first proximally to the neck and then distally to the iliac arteries or the distal aorta. The vessels are carefully flushed to remove any potential debris or clot fragments before blood flow is slowly reestablished by removing the clamps, making certain that the patient's blood pressure remains stable during reperfusion. If a bifurcated graft, Y-shaped, going to both iliac arteries is required, flow should ideally be reestablished to one limb at a time to prevent sudden hemodynamic shifts. Heparin anticoagulation is then reversed if needed, usually with protamine sulfate. Meticulous hemostasis, control of any bleeding points, is secured, and then the sigmoid colon is carefully interrogated for signs of ischemia, both visually and often with a Doppler probe to check for audible blood flow signals. If ischemia is suspected or confirmed, the IMA should be reimplanted onto the graft, either using a Carroll patch technique or a small interposition graft to restore blood supply to the colon.
And finally, the wound closure.
Yes. The wound is closed in layers, starting with closing the native aneurysm sac itself, often wrapping it around the new prosthetic graft to provide a tissue barrier. Then the posterior parietal peritoneum is closed over the graft and retroperitoneal space to protect the repair from the intestines. The remainder of the abdominal incision is then closed in a standard fashion. Just briefly, the retroperitoneal approach is generally performed with the patient positioned in a semilateral or flank position, often through an oblique incision extending towards the tip of the 11th rib. The incision can be extended up into the chest for more proximal aortic control if needed. With this approach, the left kidney is usually left down in its normal position for infrarenal exposure, but can potentially be retracted upward along with the peritoneum for more proximal aortic exposure if necessary.
Okay, let's shift gears now to endovascular principles. These are the basics that apply to pretty much all minimally invasive endovascular repairs, right?
That's right. For essentially all endovascular aortic procedures, certain fundamental principles apply. It really begins with careful preoperative planning and correct sizing of the endograft device based on the specific manufacturer's instructions for use, IFU, for that particular device. Evaluation of the access vessels, typically the common femoral or external iliac arteries in the groin, is absolutely crucial. This involves measuring their diameter to ensure it's adequate for the large delivery system sheath, and also noting the presence of significant tortuosity, winding vessels, or calcification, hardening of the arteries, which can make passage difficult or risky. Verifying healthy, relatively disease-free access arteries will often allow for a percutaneous approach, meaning accessing the artery through the skin with needles and wires without a large surgical incision.
How is that percutaneous access typically performed?
It's usually performed by accessing the anterior, non-calcified surface of the common femoral artery using a small 5 French micropuncture needle and sheath, often under ultrasound guidance for precision. This is followed by angiographic confirmation of a successful puncture into the artery lumen. Deployment of suture-mediated closure devices, if they're used for closing the arteriotomy site percutaneously at the end, usually occurs after exchanging the micropuncture sheath over a guide wire to a slightly larger 7 French sheath. Subsequently, after removing that 7 French sheath, a series of wire and catheter exchanges occurs, ultimately resulting in the placement of the appropriately sized large sheath required for the chosen endograft delivery system.
What if the access vessels aren't suitable for a purely percutaneous approach? Are there alternatives?
Yes. If the access vessels are questionable, for example, too small in diameter, heavily calcified, or very tortuous, it may necessitate an open femoral exposure. This involves making a small surgical incision in the groin to directly expose the common femoral artery. Sometimes this might also involve creating a temporary conduit sewing a short piece of small synthetic tube graft onto the more proximal iliac artery to provide a larger, healthier access point for the large device sheath. If a conduit is used, generally a 10 mm diameter graft will assure passage of most current delivery devices. Once open access is obtained, stiff guide wires should be placed up into the aorta under fluoroscopic guidance. These stiff wires are carefully used for the endograft delivery itself, as they provide stable support for tracking the large device system. The patient is systemically anticoagulated with heparin, usually aiming for an activated clotting time ACT goal of 250 to 300 seconds, which is maintained for the remainder of the case to prevent blood clots from forming on the wires or the device itself during the procedure. Limiting radiation exposure to both the patient and the operating room staff during these often lengthy procedures is paramount. The recent implementation and increasing use of image fusion technology projecting preoperative CTA scans onto the two-dimensional intraoperative fluoroscopic images, known as 2D, 3D fusion imaging, has demonstrated a significant reduction in radiation exposure, which is a major patient safety advancement.
Once the endograft is successfully deployed, what are the crucial post-deployment checks?
When the endograft placement is considered complete, and any necessary balloon molding, inflating a balloon inside the graft to ensure it expands fully and seals against the vessel wall, has been performed, a final completion angiogram is obtained. This is primarily to investigate the presence of any endoleaks, particularly types 1 and 3. Type 1 and 3 endoleaks, those involving direct flow into the aneurysm sac from the seal zones or component separation, are generally considered the most serious types and are usually addressed, if present and technically feasible, prior to completion of the case. If fenestrated endograft, a custom graft with specifically designed holes or fenestrations for branch arteries like the renals, is used, perfusion of the kidneys and absence of any renal artery kinking, dissection, or other renal injury should be carefully confirmed with angiography before finishing the procedure. Finally, closure. Closure of open groin incisions is standard after reversal of heparin anticoagulation. For percutaneous access, the large sheaths are carefully removed over a wire as the sutures of the closure device are secured. Maintaining wire access across the closure site at this point is important just in case there is either an iliac artery injury during sheath removal requiring vascular control and/or endovascular repair, or perhaps the need for placement of an additional closure device if the first one fails. The wires can then be safely removed after satisfactory hemostasis is confirmed.
Now let's focus specifically on endovascular approaches to the thoracic aorta, or TEVAR. This has really become a mainstay for many descending thoracic issues. What's the evidence supporting TEVAR in this location?
While there still haven't been any large-scale randomized controlled trials directly comparing endovascular TEVAR to open surgical repair specifically for descending thoracic aortic aneurysms, a wealth of evidence from non-randomized studies, meta-analyses, and comparisons to historical open surgery data has consistently suggested a decreased incidence of perioperative mortality and morbidity with TEVAR. This includes a reduction in the devastating complication of paraplegia. For example, in the FDA Phase 2 trial of the GORE-TAD device, Macaroon and colleagues documented impressive early mortality rates of just 1.5% at 30 days, 1.5% at 1 year, and remarkably 0% at 2 years for TEVAR. Early major adverse events included stroke at 4% and paraplegia at 3%, which compared very favorably with historical outcome numbers reported for open repair. At the 5-year follow-up point, the aneurysm-related mortality was significantly lower in the endovascular patients, only 2.8%, versus the open surgery controls, 11.7%, although interestingly, there was no significant difference when considering all-cause-related mortality. Overall survival was 68% in the endovascular group versus 67% in the open group at 5 years.
So TEVAR seems to clearly reduce aneurysm-related deaths and early complications, but perhaps not overall long-term survival compared to open surgery. What did the meta-analyses find?
A meta-analysis by Cheng and colleagues looking at TEVAR versus open surgical repair confirmed a reduction in both 30-day and 1-year all-cause mortality with TEVAR, odds ratios of 0.44 and 0.73 respectively. However, consistent with the TAG trial, this reduction in all-cause mortality was lost beyond the 1-year mark. The overall stroke rate was found to be similar between the two groups in this meta-analysis. However, this meta-analysis clearly revealed what many consider the primary benefit of TEVAR over open surgery for the descending thoracic aorta, a significant reduction in the risk of paraplegia and parapresis. So the conclusion is that, at least in the early follow-up period, reductions in all-cause mortality and major complications like paraplegia generally favor TEVAR, especially when considering high surgical risk patients who have suitable anatomy for the endovascular approach.
Okay, so suitable anatomy is absolutely crucial for TEVAR success. What are the key anatomical considerations there? Landing zones, vessel coverage?
Yes, anatomy is paramount. Key considerations include having adequate proximal and distal landing zones, healthy segments of aorta for the graft to seal against. It's usually considered adequate to obtain a 2 to 3 centimeter seal zone proximally, with perhaps extension needed if the aorta is particularly tortuous or angulated. As seen in figure 62.4 from our source material, the SABISTON textbook, there are 5 potential landing zones defined for the ascending aorta arch and proximal descending thoracic aorta, numbered 0 through 4. Zone 0 is proximal to the innominate artery, requiring complex, branched, or fenestrated grafts usually. Zone 1 is between the innominate and the left common carotid artery. Zone 2 is between the left common carotid and the origin of the left subclavian artery, SCA. Zone 3 is in the proximal descending thoracic aorta, but less than 2 cm distal to the left SCA origin. And Zone 4 is further down the descending aorta, more than 2 cm from the left SCA, typically extending to around the level of the T6 vertebral body. Landing the proximal end of the TEVAR graft requires careful consideration of these zones and the branch vessels. Proximal lesions of the thoracic aorta, like aneurysms near the arch or dissections starting there, may often require intentional coverage of the left subclavian artery origin, meaning landing the graft in Zone 2.
And covering the left subclavian artery has implications, right? Particularly regarding revascularization.
Absolutely. In patients who have had previous coronary artery bypass surgery, where an in situ left internal mammary artery, Lima graft, was used as a conduit to supply the heart muscle, typically the LAD coronary artery, it is absolutely essential to perform left SCA revascularization prior to elective Zone 2 coverage with a TEVAR graft. This is to prevent acute myocardial ischemia, a heart attack, by interrupting flow to the Lima graft. The overall reported incidence of needing to cover the left SCA during TVAR in various single-center studies ranges quite widely, from 23% to over 40%, sometimes with and sometimes without performing left SCA revascularization beforehand. In a large multi-center study, the European collaborators on stent graft techniques for aortic aneurysm repair Eurostar registry reported that 26% of their 606 TVAR patients required left SCA coverage. Now, regarding neurological complications, in that Eurostar study, there was a 2.5% overall incidence of paraplegia or paraparesis and a 3.1% incidence of stroke following TVAR. Multivariate regression analysis strikingly demonstrated a significant correlation between the development of spinal cord ischemia and having left SCA coverage without prior revascularization. The odds ratio was 3.9, which was statistically significant. Specifically, paraplegia or stroke occurred in 8.4% of patients who had left SCA coverage when prophylactic revascularization was not performed, compared with 0% incidence when revascularization was performed beforehand. This provides pretty strong evidence supporting selective revascularization in certain patients. Furthermore, Fieser and colleagues found that in their series of TVAR patients who unfortunately had strokes, a majority, 78% of those strokes, were specifically in the posterior circulation territory of the brain. This highlights the critical importance of evaluating the vertebral artery anatomy preoperatively, as the left vertebral usually arises from the left SCA, to determine those patients who might be at a higher risk for posterior circulation strokes if the left SCA is acutely covered. All of the stroke patients in Fieser and colleagues' study had coverage involving zone 02, and notably, only one of the 6 patients who stroked had received a preemptive carotid subclavian bypass.
Are there other risk factors identified for spinal cord ischemia, specifically during TVAR, beyond just SCA coverage?
Yes. Boba and colleagues, also analyzing the Eurostar data, found that, in addition to left SCA coverage, the use of 3 or more stent grafts during the TVAR procedure also had a significant impact on the subsequent development of spinal cord ischemia. Odds ratio 3.5. This suggests that longer coverage of the aorta might interrupt more critical intercostal arteries supplying the spinal cord. A meta-analysis by Cooper and colleagues reported an overall incidence of spinal cord ischemia of 2.3% without SCA coverage versus 2.8% with SCA coverage. The pooled odds ratio was 2.39, suggesting an increased risk, though maybe not as dramatic as some single studies. Anatomically, since the thyrocervical trunk branches and the vertebral artery itself contribute significantly to the anterior spinal artery, a major blood supply pathway to the spinal cord, revascularization of the left subclavian artery may indeed be important for the prevention of spinal cord ischemia in some patients by preserving that inflow. Wu and colleagues reported their specific indications for performing left subclavian revascularization prior to TVAR included things like a dominant left vertebral artery seen on imaging, a known stenotic, atretic, hypoplastic, or absent right vertebral artery, meaning the left side is critical, an anatomically incomplete vertebrobasilar system, meaning poor connections in the brain's posterior circulation, a prior history of left arm ischemia symptoms, and, as mentioned, patent Lima-to-lead bypass graft. It's worth noting that in a single-center comparison study, the reported incidence of spinal cord ischemia with TVAR was actually less compared to open repair, 6.7%, 8.6% respectively, although this difference did not reach statistical significance in their analysis.
Are there additional strategies employed to try and reduce the risk of spinal cord ischemia during TVAR, beyond just considering SCA revascularization?
Yes. Other proposals to further reduce the risk of spinal cord ischemia during and after TVAR include meticulous avoidance of intraoperative and postoperative hypotension, low blood pressure, the prophylactic or therapeutic use of spinal fluid drainage, as discussed earlier for open surgery, and potentially the use of neuroprotective medications like naloxone infusion, although the evidence for drugs is less robust. It is really important to have established preoperative and postoperative protocols in conjunction with your anesthesia team to achieve optimal blood pressure management and other spinal cord protection strategies consistently. Another important consideration is staging procedures. If the patient needs treatment of both abdominal and thoracic aortic pathology, for example a TAAA, that might be amenable to a hybrid or staged endovascular approach, performing the procedures in separate operations or staging them should theoretically allow adequate collateral blood supply pathways to develop between stages, potentially improving spinal cord outcomes compared to repairing the entire length in one go. The Eurostar study, for instance, found that having concomitant open abdominal aorta surgery around the same time as TVAR had a significant impact on the development of spinal cord ischemia, odds ratio 5.5, Presumably from interruption of flow from the inferior mesenteric artery and/or critical intercostal and lumbar artery branches during the abdominal part, highlighting the interconnectedness of the blood supply throughout the entire aorta.
Finally, for TVAR feasibility, what about the adequacy of the access vessels? Is that as critical as it is for EVR in the abdomen?
Yes, absolutely. Another crucial consideration to determine the feasibility of TIVAR is the adequacy of the access vessels, usually the iliac and femoral arteries. Ideally, an access vessel measuring at least 8 millimeters in diameter will be adequate for most current TIVAR device delivery systems. The size of the thoracic aorta generally requires larger diameter endograft devices when compared to those used for EVAR for abdominal aneurysms, and therefore will consequently require larger sheath access, sometimes up to 24 French or more. It is absolutely vital to have high-quality preoperative imaging of the entire abdominal aorta and the iliac arteries down to the femorals to determine the best access vessel based on its size, the burden of atherosclerotic disease, and the degree of tortuosity. If the native femoral and/or external iliac arteries are deemed not adequate, too small, too diseased, too tortuous, then placing a temporary common iliac artery conduit graft via an open approach, as discussed for EVAR, can be considered to provide a larger, safer access point. In very rare cases, if neither iliac system is adequate for access, then placing a temporary conduit directly onto the abdominal aorta itself might be feasible, although this adds significant complexity and risk. A dreaded complication of TVAR, as with EVAR, is disruption or rupture of the iliac access vessel upon removal of the large access sheath at the end of the procedure. This requires immediate endovascular or open surgical repair, usually facilitated by temporary endovascular balloon inflation from above for control of hemorrhage while the repair is performed.
Wow. We have truly taken a deep, deep dive today. From the complex embryological origins of the aorta, through the nuances of its anatomy, navigating the myriad of diseases like aneurysms, dissections, and injuries, and finally, exploring the incredibly sophisticated surgical and medical strategies employed to manage them. We sincerely hope you, our listener, have gained a profound appreciation for both the resilience and the vulnerability of this incredible vessel, and also for the constant dynamic evolution of medical knowledge that impacts its care, hopefully getting you closer to mastering this information, like the elite professionals in this field.
Indeed. And for our masterclass listener, perhaps consider this provocative thought as we wrap up. The very definitions and classifications of aortic diseases, as we've discussed extensively, are continually being debated, refined, and even redefined, even among the top experts. What does this constant reevaluation of fundamental concepts really tell us about the nature of medical truth itself, and perhaps about the essential lifelong journey of learning required for true mastery in any complex field like this? It seems it's a continuous pursuit of deeper knowledge and ongoing improvement, where what we think we know today can always be further deepened or even fundamentally redefined tomorrow.
Yeah, absolutely. A fantastic point. This deep dive, as comprehensive as it was, is truly just the beginning of your understanding. We encourage you to reflect on that dynamic interplay between structure, function, and pathology you see throughout the human body. What other complex truths might be awaiting a deeper dive for you?
Join us next time on The Deep Dive for another journey into being truly well informed.